Dobré utro, good morning. We are so small group. So today we have issue around GIT complications or GIT symptoms of cystic fibrosis and therapy of these symptoms, and a very important part of CF therapy, what is nutrition. I very often feel how on one side it is very important to focus also on the nutrition of CF patients, but on another side, because it's very simply, it's every day, but it creates very often so many complications for family and very hard situations in families, and a lot of fear around food and around nutrition of their child. So maybe I ask our CF doctors to say a few words about gastrointestinal symptoms of cystic fibrosis and why this nutrition therapy is so important for cystic fibrosis patients. Okay.
Hello. Good morning to everyone. We have more like a little group today. Not many people left, but the hardest one, the strongest ones. And the topic is really very important. It's the subject from which actually we begin the treatment of cystic fibrosis, gastroenterology issues, and pancreatic insufficiency issues. This is what arises in the womb. And all we know that on the 5th month of the fetus development in the womb, already our patients have sonographic signs of pancreatic deficiency. And we heard a great speech about the neonatal period of development of these kids, and we know about distal malfunction in our kids, which we face very often. So we cannot omit this issue. It would be totally unreasonable. Despite this, despite the fact that our conference is more dedicated to physiotherapy of CF patients, another very important task for nutrition of patients with cystic fibrosis is that if a kid does not have a normal nutrition status, he or she will never be able to do physiotherapy at the very efficient level, because physiotherapy is time and energy consuming. So we need to do our best in order to give energy to a child before the physiotherapy. Please recall my speech and everyone's speeches yesterday regarding physiotherapy. It is very important to replenish the energy after physiotherapy. And thank God we have energy supplements. Various companies suggest us to use these supplements, additives. With fibers, it's nutrition with fibers. I'll recall the title of this medication, but it's 240 kilocalories in 125 milliliters of this mixture. So a child can take this mixture and without straining himself or herself after physiotherapy. And also, as for the muscle tonus, it's very important to use fat soluble vitamins like A, D, K, vitamins A, D, K. In Ukraine, it is somewhat difficult, like every half a year or every year, according to the international protocol recommendations, it is recommended to control the level of vitamins. But lately we started to trace the vitamin D availability because we are living in Carpathian region, and insulation of our solarization of our patients is not sufficient for nutrition of our patients. So according to my research over the last year, this was also stimulated by the COVID pandemic, because we read the publications that COVID is survived by worse by people who have low levels of vitamin D, and 50% of COVID patients had vitamin D content of lower below 30%. And vitamin D in patients with cystic fibrosis, and even in normal state for every person, it should be 75. But in our laboratory, they assert that the norm is higher than 30%. No, it's not true, because the North American Association ascertains that their norm is 125. How can it be 30%? 30, the norm of vitamin D. We know that our patients have a good compliance with vitamin therapy, but have a low level of vitamin D. That's why we decided to decrease the vitamin D in nutrition. So children's patients began to be more susceptible to the therapy. And yesterday, despite the fact that we had a roundtable on physiotherapy, Larissa asked a question regarding nutrition and feeding through gastrostoma, and about motivation of patients for using gastrostoma. It was a very interesting discussion yesterday. So I kindly invite everyone to discuss it right now, because everyone has an experience of working with CF patients. Please turn off the sound of your phones or the phone. We would be really grateful to you. So I kindly ask everyone to express their opinion on this point, to share their experience, how you resolve these issues. And if anyone, let's say, has another question for discussion, we will discuss it jointly.
I just want to say, yesterday I had a lecture, and as you remember, it was it was Laura, it was a girl who was 4 weeks old, and from the beginning she had problem with weight. From the beginning she had problem with nutrition. It means the early we make diagnosis for cystic fibrosis, and it was one of the one of the best results from screening, that these children had better nutrition. After better nutrition, they had better pulmonary function and better lungs. But first, the best results was that children from newborn screening had better nutrition. And after that, all other results become true and becomes better. From the beginning, we have to take care. Immediately after diagnosis, we have to take about nutrition. We have a special outpatient ambulance for nutrition. We have this ambulance for nutrition for all kind of chronic disease. There is a dietitian who take care about nutrition for each group. She had a protocol for cystic fibrosis. She had protocol for chronic renal failure or other disease, other patient with chronic disease. And she asked parents to bring 4 days jedálniček. 4 days menu, what they used to give at home. 4 days. For example, soup, how much soup, how it was this soup and something like that she can count calorie. And from this 4 days menu, how she count, she said that if it is enough or not, if it is enough sugar, protein, lipid, and she also advised what to do or what to add for a meal or to the meal for these children. Before we start, I remember we have one very nice CD. Do you remember? Game. It was a game for children. And in that game, it was from the beginning, I will say, you are a girl or boy. How old are you? What are you doing? And after that, you wake up in the morning. That boy, for example, goes to another room. He starts to do inhalation. It was a picture, move. It was like a movie or something like that. Game, yes, game. And after that, he went to the refrigerator. He opened a refrigerator. It was eggs, 80 calorie. It was butter, I don't know, 150 calorie per 10 gram. He took this meal, and after that, it was counting. He started to eat, and after that count. Yes, he eat that and that much calorie, and after he went, for example, for running. It was written, this is running, you spend so much calorie, it means you have to eat more. After that, it was lunch, it was dinner. At the end, it was counting how much he took and how much he spent, if it's enough or not for his age, and for that for his moving or sport. Yes, it was really very nice for me, and now I remember this one. And it should be something like that, not only how much this child is able to take or how much he eats. First, you have to know how much. If it's enough and if it is good balance. Not too much sugar, more protein. If, for example, has problem with glucose tolerance, he cannot eat so much sugar or only some kind of sugar. Yes, but this, you know that, or usually I used to say to my patient, if unfortunately, if you eat 1 gram of sugar, it is 4.5 or something like that calorie. If you eat 1 gram of lipid, it is more than 9 calories. It means if you want to give them more calorie, you should eat more lipids, because you are not able to eat from the same amount of food. You cannot eat twice or 3 times more. You must have more calorie in that the same amount of meal. It means you have to put the lipid. Yes, you have to put the lipid. You have to put smotana, cream, or nuts, or another food which contain more calorie. It means more lipid. Yeah. Okay.
Okay, I would like to ask that everybody come in the circle. The participants, please. Nadia? I think we have enough space. So maybe I will tell some facts and statistics. You know that there are almost 2,000 mutations of cystic fibrosis gene. So there are much more variants or clinical variations of cystic fibrosis. But one important statistic is that 85% of cystic fibrosis patients have pancreatic insufficiency since they born, or it will develop in their 1, 2, 3, 4, 5 years. What means that the exocrine part of pancreas not works. Without pancreas, we cannot live. So this was why the cystic fibrosis children died until they 3 years before the therapy. Now they live longer because in the therapy they have pancreatic substitution, what is Creon, pancrease, or I don't know, many other preparates or drugs, but they have to use this pancreatic substitution for their whole life, every day, with every piece of meal. Only for fruits they don't need to eat. So this is one important thing that they need to know, that really to every piece of food they have to take Creon or pancreatic enzymes, because their body is not able to use this food without enzymes. And then on the other side, if the CF patients have body mass index lower than 18, they are excluded from transplantation program. They send them home and say them, please gain your weight. And if their lungs are 30%, they never gain their weight for more. So they have no chance go for transplantation. And this is important to know why the weight is so important. Because really the transplantation needs somehow strong body, strong mind, because it's strong bones. And also the osteoporosis is also what is the part of nutrition, vitamin D, and all vitamins, all minerals. So it's really big complex of things around nutrition. And because the pancreas not work, they have substitution, but it is never 100% full, how to say, that this works like in healthy people. It is still only maybe 70–80% of normal digestion. And because they have lung infection, they need a lot of energy to fight with this infection every day. So this means that they really have to access to pancreatic enzymes. What I know in Ukraine is you never know. Every year it depends if the oblast will pay or buy or not buy Creon for CF patients. But now I think it's better as it was 10 years ago. And then the intake have to be higher than in healthy children or healthy people, more plus 50 to 100% of energy intake. But this is very difficult because they are not able to eat twice more amount of food. It's really sometimes difficult. And we know, or many of us, that their appetite is low. Maybe they have pain in their stomach, or they have antibiotic therapy, what also create low appetite or some pain or some, I don't know, many complications. Yes, smell and yes, and taste. Yeah, because of physiotherapy. So there are around this, there are really many aspects of nutrition. But because of transplantation, this is very important to know. And then is this therapy with modulators. They work like mirror, but everything what is damaged in the body before they start this therapy, it's not repairing, so it stays damaged. So this just work with the body, how it is in the moment when they can start this therapy. So as Anka Feketova told, we also was in this situation, how to solve the nutrition of CF patient, because everybody say them, you have to eat high caloric diet. But what it means in the age where everybody want to be slim and everything is low calorie, everything is zero fat. So we really, and all diets are about reduction of weight. So we as parents were very active and tried to find some people who are interested about nutrition. So we found such a person, but not in hospital, unfortunately, on the beginning, outside. But we started to organize meeting for parents and adult patients and cooking, going with them in the shop, showing them which kind of products are good for them, high caloric, healthy. Then this woman started to cook with them and teach them how to prepare food, nice, tasty, and high caloric food, but in small amounts, so some kind of caloric bombs, because most of us know that our children, maybe they are hungry, they want to eat, and then they eat maybe half of the portion, and then they stop. And this woman wrote the book. We asked her, okay, so write some book about nutrition. So she wrote first book about nutrition. And 5 years ago, there was also another person who was really very active in the nutrition for CF. And she updated this book and put there more information. And this is Slovak version of this book. And because we have this project, we were able to translate this book in Ukrainian language. And I am really thankful to Lyudmila Bober, Monika Maki, and Nadia Fomenko that they do Ukrainian corrections and control that all translation is correct and the informations are correct in this book. Everybody, every participant received one of this book, but we printed more of them. And we distributed it in the Ukraine. If you don't have enough, it's very simply, there is electronic version. You can find it on the website. But also you can find some sponsor and print from this electronic file how many books you need for your patients. And in this book, there are really many informations, but there are also recipes from these two women, these two nutritionists, how to cook high caloric, good taste, and in small piece, a lot of calories. And I have here, also in the book, you can find, but you can do it, of course, your way. Monica, can you help me? And give to everybody one of this and one of this. So this is what you can give to patients and parents to write his 4 days or 5 days menu. You have to give them some time. So this is one of the possibilities. There are simply advices how to write what they eat, and there is the table, and they can write this. But then it's important to have in the CF center person who know what to do with this, who can count. But also now on the internet is everything, so you can also, there is possible to find some programs which count the calories. And this is very simply tool which you can use in your practice with CF patients and do it minimally once a year. Just check what they really eat, how much calorie is their intake, and then if you see this, then it's then are more possibilities how to solve the situation when you see that their calorie intakes is too low, not enough. So one is to cook more caloric bombs and believe that they will eat it. Check if they really use enough pancreatic enzymes, because sometimes they really need very high dose of these pancreatic enzymes. Don't worry about high doses. It's safe. And because sometimes they need 4, 5, 10 capsules of Crown, what looks crazy, but they really need these enzymes, because without pancreatic enzymes digest 80 to 90% of the food. So it's basic for our life. And so this is one possibility, but very often this is not enough. This is for you, for your center. And then you have a next step. There are some, how to say, nutritional, supplements, sipping. Everything is written in this book, so please really read this book. You can find there really a lot of important informations. And this sipping, so I think that now everybody knows there are many companies who create these sipping and supplements. You have Nutricia, you have Fresenius, Nestle, Nutri-Drinks, Nutrisons, I don't know, many of them. They are small bottles, 2 deciliter, and children can just drink it. Again, it's good to find good management of using these supplements, because because the way is not, they have eat also normal food. This have to be some extra calories, not instead of the normal food. Very often, the companies really try to create good taste of these preparates and supplements and new tastes, but still, many children don't like this taste or something. No, you can. In this book are also a few recipes from the supplements. So the parents have to be sometimes very, very creative. It's easier with adult patients, but not everybody. They can, be more rational, and they are able to drink it because they know that it's important for them. It's good maybe to drink it before they go sleeping, after a whole day, after normal food, and put more extra calories. So this is another possibility, but again, it is not cheap version, and it depends on country if it is covered by insurance or healthcare system or government or not. We in Slovakia were 20 years ago very, very active in this way, and we had one doctor. She was not working with CF, but she was very strong in nutrition and good nutrition, not only for CF. But she cooperated with many patient organizations, and so we together pushed on the Ministry of Healthcare system. And now in Slovakia, not now, it's more than 10 years, many years, the insurance system cover these supplements to not only CF patients, it is good for oncology patients or for, I don't know, there are many other diagnoses. Sometimes all geriatric patients drink this, or so, oncology. So we are very, very lucky that our patients have access to these supplements, and many of them drink these supplements for many years. And then if this not work is not enough, then it's really good to think about gastrostomy. And this is very difficult step, as we listened yesterday a lot about this possibility. But I can say that it's in some indications, this is the only way how to gain weight for cystic fibrosis patients. It's create maybe many complications, but how to use this possibility means that they have to have this gastrostomy for, not for months, half a year. Usually they need it for many years. And it means for family that every night you have to put this bag with 1,000 or 1,050 calories in 1 liter on the hang it, and whole night this nutrition goes to their stomach. Again, it's important to find good management of pancreatic replacement, because they want to sleep. But I can say you that if they have it after first maybe days or weeks, they are okay, the children are okay with this gastrostomy, they are able to be active, they can sleep, they have no problem with this.
But you know she has her own experience with.
Yes, I have my own experience. We had 3 years, my son had 3 years, and I think that it's good, it's very important to find the right moment when start, because in some moment it could be too late and it will not work. So according to my experience, very important or good age is really the puberty or before puberty, because this is the period of life when really is the biggest growth of the bodies. Young bodies, they are active, and they can really, the normal adolescents or puberty children eat like crazy, a lot of food, but not CF patients. So this is good age when you can support the body really to use and to gain weight for rest of their life. Okay, so this is maybe what I wanted to tell you, and now maybe, yes, we can go this way and everybody can say something to this issue.
I want to speak only about my experience. How it is important to speak with parents and with the patient about nutrition, because you think that you know your patient, but you don't know them. You don't know what they eat, how they eat. I thought that I know, but we have one clinical study. And in that clinical study, it was a study with new pancreatic enzyme. And during this study, they had to write how many times they eat, when they eat, and how much they eat, and when they take this pancreatic enzyme, yes, at what time. And when I took this paper, this sheet, I was surprised. I was surprised what my patient and when my patient and how frequent my patient eat. I had, for example, one patient. It was a boy around 10, 11 years old. He eat during the day maybe twice, and in the evening from 8 o'clock up to 9 o'clock or 10 o'clock, he ate 6 times. Of course, he could not gain any weight. Or one of these patients eat only soup. It was really surprising because you are not a nutritionist. Yes, we are pulmonologists, we are CF doctors, and we take care about nutrition, of course, but I will not speak with my patient about such details of their meal. It means we have to ask our patient, and maybe we will surprise, and maybe it will be not so difficult to help them to improve nutrition of our patient.
I'd like to continue emphasize your attention on the sugar diabetes related to cystic fibrosis, because if it's not diagnosed, if sugar diabetes is not diagnosed with cystic fibrosis, then it means that all the measures of hypercalorie diet, of gastrostome, all these measures won't be effective, even with really good appetite, although sugar diabetes very likely will go with polydipsia, not appetite. Children will lose body mass, and that will happen due to the muscle mass which we really need for physiotherapy, for normal life, and so on. The particularities of sugar diabetes with CF is the fact that it's not of the first or the second type. The particularities of sugar diabetes with CF is the fact that it can give long-term remissions. And this long-term remission may be only when we stabilize the condition of bronchial lung system, or when we treat some aggressive and important bacterium. The particularities of sugar diabetes with CF are the fact that it's difficult to diagnose it. Primarily from the beginning of intolerance to glucose to diagnostics, it can take a few years. And when the doctor looks back and analyzes what was happening during the previous few years, the child regressed in the body mass and accordingly regressed from the side of bronchial lung system, given that the child complied with all the doctor's prescriptions. It's really important with CF, it's possible for the patient to receive insulin for a while, and then to stop using insulin when the condition is stable. It's really important and intimate area for our patients, because most often it starts during teenage period, and teenagers are quite shy, and Mrs. Katarina said that they have to have really crazy appetite, and if it doesn't happen, then you have to think about sugar diabetes. Maybe this is sugar diabetes. Also, I'd like to highlight the fact that sugar diabetes with CF is specific because the diet therapy is different from the diet therapy with sugar diabetes of the first and second types. Our children, they don't get deprived of carbs. The carbs are the same because it's one of the energy elements, and it's important to prescribe the right dosage of insulin and to achieve normal glycemia. And one more particularity of insulin insufficiency of pancreas is the fact that the deficiency of insulin takes place during the second part of the day. That means if you give the child with sugar diabetes the monitoring of sugar from the morning till breakfast, you mostly will have the norm of glycemia. You won't even have 6. But hyperglycemia happens after lunchtime, after 4 p.m., which means that lunchtime takes place, and 2 hours after the lunchtime, sugar has to normalize, but you will have the opposite result. It will grow. Of course, it won't be 11, 12, or 20 right away. Also, I have one more experience related to the use of insulin with sugar diabetes when we use pulse therapy with methylprednisolone. And since it happens during the teenage period, I have a patient who is 12 years old from the city Vinnytsia, and I have children of 7, 10 years who still have allergic bronchial lung aspergillosis, which we treated in this way. Not to rise glycemia, we gave insulin for prevention during the time of pulse, and after the usage of pulse therapy, children recovered much faster. And when after 1 month they had to come for next pulse therapy, they had normal glycolic hemoglobin, they didn't have any insulin symptoms, and they recovered. Because one more time, I'd like to highlight that sugar diabetes with CF will show the regress of body mass with which you won't be able to deal with. Thank you. I want to thank for our speakers.
I would like to thank you for your interesting opinions on to all specialists who talked about this, and it is very important for all of us because those who really are deeply involved in treatment of cystic fibrosis, all these specialists should be knowledgeable in basically numerous fields in nutrition, in gastroenterology, in pulmonology, in every field. But basically, we always mention that our nutritionists should be actively involved. They have to calculate calories and all basic nutrients for every child, by which a child will get the necessary energy. I would also like to add that it's a really great book, since our hospital and me personally, let's say, we're kind of characters. We really know the text, and it is wonderful book because it all begins from the beginning, what the nutrition ratio should be for all ingredients, like lipids, proteins, and carbohydrates, and what kind of vitamins should be given. And it is wonderfully written here how to treat diabetes in these kids. And then there is a great section dedicated to the issues of various indications and how various therapies are used, including gastrostoma as quite an invasive and aggressive method of treatment. But at certain point, it's just impossible to avoid this method if a child needs to be saved. So this is really a wonderful book, and for everyone who will read it, it will be extremely useful. Another question is that as a professor in the university, I in particular read lectures on pancreatic insufficiency, and when we and also the deficit of vitamin D. We studied this for all kinds of people and patients with cystic fibrosis in particular. This is really the truth and the dogma which should not even be discussed. That, for example, if we have a protocol for treatment for early age from the years old, and we have certain norms for vitamin D, but it's about 1,000. In some literature, it is stated 500, but this doses is several times higher than normal, and we really need to remember that. Speaking of the diet during cystic fibrosis, and high calories, which should be in meals two times more than normal meals. And first of all, kids should be nourished with lipids and proteins. But the paradoxical thing is that when a person has diabetes, we also give carbohydrates, and we calculate how many units of lipase we give, not pancreasa, not diastasa, but lipase in particular per weight, because the biggest problem is actually new digestion of lipids, and this is the specifics of the diet when a person has cystic fibrosis. Also, I would like to say that since we have pulmonologists here who work with kids and adults, she's also present with us today. Yes, so all of us are here, all of us are in the team, and I would like to say that especially when we work with early age children, I also mentioned that there was one of the patients, very difficult patients, recent patients, and he's in our hospital right now. I will kindly ask Ludmila Yosifovna to examine him together, taking into account her tremendous experience. But it's really a very difficult case because he has a problem already, since we know that already in the womb, in the body of a child, the wrong malfunction of the pancreas is involved, and there is actually a whole problem with just digestion. We just cannot do anything, but with this child, there is also some problems with the structure of internal organs, and he has pneumonia in addition. And there is such an energy-consuming life or existence of the child. It requires so much energy. This child, I think, he says 10,000 units of lipase per 1 kilogram of weight. That's the way we try to do this. Yes, Ludmila, but this, in addition, this child has low appetite and anorexia even, so we have to use protein additives, Peptisorb, and with lipids, etc. And only this way we succeed to somehow ensure gaining weight by this child. Such kind of patients is really, really heavy. And also Katerina mentioned that about 85%, and according to the world statistics, 85% of people have pancreatic insufficiency. But to be honest, we have 33 kids and we don't have replacement therapy with Creon. So I believe that if we don't have obvious pancreatic insufficiency, and like, for example, we determined pancreatic elastase less than 200 units, and but we not a single child of ours goes without this replacement therapy, ferment replacement therapy, enzyme replacement therapy. By the way, the patient which moved from Tsap, the last name is Tsap, he moved to us in his like 5 months he's here, and it's the only patient who has overweight. He has 2 mutations. He has fecal elastase of 5 or 700, but when it comes to fatty food, he gets Creon capsules, because in response to your question, I would like every patient to have Creon, because at any point fecal elastase can decrease, and these patients need to have repeated therapy with fecal elastase and check of fecal elastase, because we should not miss a point when creon should be prescribed, because once they will definitely get pancreatic insufficiency. And those kids who do not have it, they are in the risk zone of the early failure to diagnose the situation. And according to literature, why there is such a percentage of kids without it? Because we miss these cases, unfortunately. That's why they have asthma, bronchitis, problems with the development of respiratory system, and they come to us when they are already teenagers, and we start diagnosing various types of bacteria in them and cystic fibrosis. They're exhausted despite the fact that their pancreas is sufficient. So they have such a tremendous energy expenditure on fighting lung infections that even with the sufficient pancreatic function, they cannot maintain normal body weight and they do not grow. So physical development of a CF patients have such comprehensive, components, many components. I mentioned pancreatic enzymes. I mentioned diabetes, pancreatic enzymes, and also high dosage therapy. It is very difficult to select a dose of pancreatic enzymes after the surgery in kids. For example, when a kid is eating 20 to 30 grams or milliliters of food, at the same time we hear that he gets 10,000 units per 1 kilogram of body mass. I cannot, so far I cannot understand how it is, but I would like to see the patient because still pancreatine is provided for meals. We should better start with half of a dose because nobody knows how much a kid will eat. So pancreatine should be provided when there is a good passage of fecal masses. We have experience with big bellies, with stomach problems, with internal in the stomach pressure, high pressure, and this compresses the lungs and doesn't let them work properly. Basically, cystic fibrosis means pediatrics from minimal to major problems. It's mentality problem, like we mentioned. Fat soluble vitamins. The insufficiency of vitamins, especially vitamin E, leads to decrease in a patient's cognitive ability. Also, the iron deficiency, iron deficit. Patients who come to us for consultations, they should admit that every time when a patient comes, we determine the level of iron. Also, we start prescribing fat-soluble vitamins, not all the time, but maybe once a year, maybe depending on the indicators. And these micronutrients are so important and they're so influential, like zinc, for example. Low zinc content influences appetite as much. For example, yesterday we heard about smells, about appetites, and how a child is stimulated to eat. Food should be beautiful and tasty. A child should look at the meals and want to eat it. And still, this will not be a definite prognosis that a child will eat everything you give him or her. So you can give one capsule of creon before, but if you see that a child is eating with healthy appetite, you will give another creon capsule. But overdosage with creon is a very terrible also point, which can provoke surgeries, bad health, and bad self-feeling of a person, and nutrition problems. Thank you very much for what you added, but still, Ludmila, the surgery was on the 2nd or 3rd day. His post-surgery, you will see him definitely. But I think that we started with this optimal dose for the child because he basically had anorexia. Now he's he has about 700 milliliters and he tolerates 1/5 of the volume, and this is normal. But the only point that he really doesn't have any energy to swallow. He takes this from zoned mostly. So when parents don't want to use the zone, when they switched from zone to another device, the child lost weight immediately. First of all, I would like to thank everyone. These are so important practical advice which all of us will use. And I would like to ask the following question. We have a cystisorb, which we prescribe to CF patients. Could you please say whether we need to also prescribe vitamins if a patient takes cystisorb every day? That's question number 1. And question number 2, maybe right away. May I? Okay. Adult patients, most all of them have gastrointestinal problems and inner stomach pressure, and inhibitors of proton pump are described like there are data for adults that noprazoles at the adult age since they're competent with other medications, basically they can cause osteoporosis in adults. That's why I have question. In the adult age, it is recommended to prescribe molecules of pantoprazole, but why is in the protocols of CF treatment we have other I prescribe to my adult, I prescribe pantoprazole for adult patients. So my question is about cystoprazole and pantoprazole.
Maybe I can say something to this cystisorb. So CF patients, because the digestion is not full, not correct, they need to supplement not only vitamin D, A, K, but all vitamins and also many kind of minerals. So some companies created, because then they had, 10 boxes of A vitamin, magnesium, selen, zinc, I don't know, so many pills. So some companies try to create it special product, wherein one tablet is everything, and because usually CF patients need high doses of these minerals and vitamins, because there are many products, multivitamins, multiminerals, but usually the doses in these expensive products are not enough for CF. So one of the, I remember there was Aquadex, MVM, Decas, I don't know, and the cystisorb is Polish product, one of them. So it was in the CF pipeline, the Aquadex was one of the, one of the most, it is in this list of the advices and recommendations and a product of trials and science for CF, how to give them really everything what they need. So cystisorb is one of the product, and yes, they need to use it every day.
But not other vitamins.
But then it's, yes, enough, just use this vitamin. But it's if you are able to check the level of other vitamins, so, and if it's not enough, then you can add him more.
Ну, але вітамін К, я не знаю, як його визначити. От мене цікавить, чи додавати вітамін К до цистісорбу, чи не додавати. Я не знаю, як визначити вітамін К.
I don't know for adults because I am children pulmonologist, but for children there is no strong evidence that we have to give K vitamin. We don't use it for every child. We use only in some situation, or we use very individually. We don't use for everyone.
I know from where this question arises, because in our center, we practice such things that kids get multivitamins, Decas, Aquadex, Otsissorb, and separately they get vitamin D.
And I've come to conclusion that due to my research and experience, I can't understand whether these multivitamins, water soluble, are not fully absorbed or they are taken the wrong way, because they had to be taken together with cryon, despite the fact that they are water soluble. So water soluble form, I mean, why they're so expensive and why is it so difficult to produce them? Because oil vitamins are turned into the water soluble ones. So theoretically they could be absorbed without cryon if it's water soluble, but practically we receive a different situation. Out of the research I've done on vitamins over the last 1.5 years, I understood that vitamin A and E are normals and vitamin D is too low, but it is still there in the multivitamins. Besides, it's not only there, our children received from 1 to 2 to 5 drops extra of vitamin D, and it is still low, and not just a little low. If, for example, 75 nanogram per milliliter, I've seen the situation where the level was 20, 25, 11, 15. It's a disaster. So what's happening with the bones of the child who intensively grows the first 3 years, then during the teenage period, now in terms of vitamin K? For a longer period of time, I had the orient coagulogram, and the children who during hospitalization, a lot of children during the hospitalization for prevention or for treatment of all the diseases, we examine with coagulogram. Prothrombin time is increased for almost everyone, and it increases even more when we give antibiotic therapy. And our children receive antibiotic therapy very often periorally. And there are children who are almost non-stop on one or other antibiotic therapy or on the rotation of antibiotics. So basically, I believe that this vitamin has to be there, apart from the fact that vitamin K also influences osteoporosis. And if we speak right now about the bone system only, then I have the data, and it's not the new data. I've found out about them just recently. Vitamin K1 and K2 are different vitamins. K1 influences the blood coagulation, and K2 influences on the formation of the bones. I found out that in Kiev there is a laboratory which measures the levels of K1 and K2 in 2 fractures. So yes, but it's really expensive. I mean, one research will cost about $100. For average Ukrainian person, for average Ukrainian family, it's quite costly. I'm not saying that you have to do one examination. CF means a lot of examinations, a lot of financial pressure, and I'm not gonna speak more about it. Patients know it. And once a year, especially where we need to understand whether this patient needs to be prescribed for vitamin K, especially the adult patient who has the threat of lung bleeding or gut bleeding, and we haven't even touched upon the topic of fibrosis of liver and portal hypertension and liver cirrhosis. We can even have one more conference about this topic. So it's with the prevention purpose, but the overdosage of high coagulation or something like that, I haven't faced that due to vitamin K. So in my head, I have prevention of infections, vaccinations from everything that's there. And all my patients know that it's important to get vaccinated, and the children will get vaccinated from COVID. Our patients will be the first ones to get the vaccines against COVID. And I think that our center promotes vaccinations most of all. So personally, with the purpose of prevention, and since the research has shown that the indicators are low anyway, and the vitamin A normally is on the good level, and vitamin E a bit higher, or almost on the borderline of low level. So in terms of omeprazole, the other question, omeprazole, yes, gastroesophageal reflux is a huge problem, which can be associated with relapsing bronchial obstruction, atelectase, in particular about the upper area. If on the X-ray we see the relapsing form, then it's bad controlled reflux, or the motorics of the gut system is disrupted in general. That's why we often use it, and there are patients who non-stop get omeprazole. In terms of pantoprazole and omeprazole, I cannot continue the discussion because this is new information for me, and I thank for that. I thank everyone who says something new, because it's impossible to know everything. But lately, the patients who behaved really aggressively, I prescribed the combination of mebrazole and famotidine. And then they really answer well to it, because pantoprazole or omeprazole, the inhibitors of proton pump, they influence one group of cells. Aquamatel influences H2 blockators, absolutely different cells, which will also stimulate the acidity. And in particular, it will happen during hospitalization. Why? Because the intensity of physiotherapy goes up, hypodynamics of the child because of hypodynamics of the child, because the child is on antibiotic therapy, and relatively the children recover. And I have a lot of children who have bad appetite and they don't recover. And I have the minimal aim, 1 kilogram of weight gain. So if the child gains 2.5, 3 kilograms, that's great. But when the child loses weight, it's a disaster. So the combination of Guamatel and the inhibitors of proton pump, I will listen to the information and the information about omeprazole, and I will take it into account. I'm not sure. It's not even the answer to the question. It was just my rumination or thinking, but that's what I could say based on my experience. If I may, I'd like to add the following. In 2019, Martina Szwajka came to Lviv. She's from Poland, dietologist, and she has CF herself, who developed the diet for CF patients and who promotes in Poland nutrition diet, and she does it professionally. And back then, I knew about such meeting. I called for parents who have children with CF. Martina was showing a lot of interesting information, slides. And it happened this way that all the parents took pictures, they engaged to her group on Facebook. And after a while, after COVID, we opened up and I faced the situation that there were the patients whose parents visited Martina's meeting and asked a lot of questions and copied the recipes. And to my disappointment, I have high disappointment. Nobody complied with the recommendations of the dietologist. Unfortunately, no one, you see, every adult, any adult and maybe a child has some nutrition preferences and dietary habits. So knowing my patients, I thought that something would change, but no. Briefly, it was like huge work was done. You see, we probably need to change the mentality of children and their parents, the mentality of children and adults. And I don't know how to get it across to them, but this is the problem number one. Because they do physiotherapy, antibiotic therapy, but in terms of nutrition, even if they don't listen, even if when they hear such speeches and they see an adult patient with CF, this is huge work and very necessary work. I'd like to ask. I have a question. My son is 3 years old and we still cannot swallow cryon capsule. I put the content of the capsule on the spoon and he swallows it. And as I understand, it's also not the good way. Maybe you have some life hacks how to teach the son swallow that cryon capsule. Out of my example, we've also had such problem. We tricked the child. We started 10,000 capsule and in between 25,000 capsule, and she didn't even notice when she was swallowing 25,000 capsule. It was our way then. It was really interesting for her that she could swallow all at the same time, and I was just monitoring whether everything was going well. You see, trickiness works. I give him 10,000 capsule and he eats the food and the capsule may stay under the tongue for 5 minutes, and I check and it's still under his tongue and he eats, swallows the food and pretends that he swallowed that capsule. This is the individual. So individually you have to find something. The big problem is that it happens like that. I'd like to say a few words about the reaction of the quality of life. It is identified by the function of all the systems. The lung system is the leading system from the point of view of CF, but gastroenterological manifestations and gut manifestations we undervalue sometimes. We forget about that because we are pulmonologists, and during physiotherapy we were informed that we have to correctly ask the patient whether he or she has farting or bloating, what he feels, how did he poop, and in what way. This is something that we don't really discuss. Sometimes they can even feel ashamed of that, but it identifies the quality of life mostly, especially when the child attends school or kindergarten. This bloating and farting, the stomach ache, the child probably pays more attention to the fact than it's difficult to breathe or cough. Coughing is also worrying symptom, but when we see our patient, we can ask him about other gastrointestinal symptoms. And such trust relations, they will mean that asking this question, we understand what may worry the patient. We shouldn't necessarily avoid such conversation. And the diet, nutrition, of course, we can improve it. We can talk about doing one way or the other. Let's eat better and so on. And maybe the symptoms, they will disappear and we will take the maintaining therapy to maximum. Of course, it'll save maintaining therapy because we don't have a lot of it, and it also influences the quality of life of the patients. Just a comment. Thank you. The despair that is there in contrast to previous years. Good afternoon. I'm very happy to see everyone here. This is the first time for me that I face the situation of progression, not regression, over many years. I'm a pulmonologist for 38 years in our hospital. The first children who were our patients together with the department, Halina Ivanivna Maguryak helped us back then. You see, right now, I look back and it gets I get happy and I get very sad over the period of time we lost in terms of treatment and the right management in terms of nutrition. And you know, I remember all the children we lost, and we had family cases as well. There was a nurse whose daughter over 4 or 5 years died one after the other one. And the treatment back then was so limited in terms of availability. I remember only gentamicin we prayed for, pancreatine, and when I read the articles of Italian specialists and compared the quality of gentamicin of their quality and pancreatine of their quality and our pancreatine, and their patients lived, there was the minister of machine construction, he was 34, and when you visually look at those patients who have the right management and our patients, I felt so sorry. And right now I am on the stage of modern time and right approach, and I want to get back in time. And how would the patients we had in the past, how they would get the right treatment, how they would, in different ways. And I'm really impressed with your, not with our, but with your accomplishments. And I'm so proud of the fact that we are catching up with you. And I think that we will catch up with you and we will be on your level. And I believe, although I am quite old, I doubt I will participate in that. However, this uplift and the belief in the better is here with me. And I thank you for being here with us. I wanted to ask the representatives of Slovakia about Orkambi. You know that I know that your patients get Orkambi. So do all your patients get Orkambi, or only the ones in complicated condition who need it more? And the second question, I know that Orkambi in many patients has side effects. What about your patients? Do your patients on Orkambi have side effects? I want to hear about the side effects from Orkambi.
All our patients had Orkambi. We have 10 patients more than 2 years old and less than 18, less than 19, because we are only pediatric. We have only pediatric patients. It means all our patients who had genetic examination and who are homozygote. It means has 2 allele, 2 mutation, delta 508. Yes, all patients had Orkambi. This Orkambi we have since last September. It's covered by insurance, health insurance, and some of them from the beginning we hospitalized because we were afraid about side effect, because it is written everywhere, and also our colleague from Czech Republic who had experience with this treatment spoke about side effect to take care and like this. It means we put these children in the hospital, and some of them had some tightness on the chest, some, let's say, some bad feeling in the chest, that they could not breathe well, but it disappeared. And none on this side effect was a reason to stop this treatment. All our patients to who we gave this treatment, all these patients have this treatment up to now. We have this treatment from our health insurance for 1 year. After that, we will see what and how it will be again. But I hope that we will prolong this treatment for children under 12 years. And I hope that for all patients about 12 years, we will be able to put on Kaftrio. Because now we have this Kaftrio, and it will be from the 1st September for our patient. But I don't know still now all details about prescribing this Kaftrio. But I know that we will have. It means I hope that it will. None of these patients had so bad side effect to have us to stop this treatment. But it is in literature, and also our colleague from Czech Republic spoke that they had some patients, but it's not our experience.
So I can say you that we have in Slovakia 6 official CF center, and some treatments for CF patients have to be prescribed only by doctors in their CF centers. What means that once every patient have to come to CF center to receive appropriate therapy. So in all of these CF centers in Slovakia, the doctors prescribe Orkambi. So all CF patients in Slovakia who have delta 5/508, okay, mutations, they receive Orkambi from last September, October, November. As I know, there are maybe 1 or 2 patients who had to stop Orkambi in Slovakia, but in some other center. And because we will have Kaftrio from September, so we all expect how it will work, how it will be prescribed, what administrations, and so on. But there is still some limited budget, which is not enough for all patients. But I suppose that slowly we start with patients with 1 delta F508, and then we maybe they don't have Orkambi, so this will be the beginning, and then slowly maybe some patients from Orkambi will go on Kaftrio too, because the budget is not for all. But we will again do something after 1 year, evaluate it, and then we slowly. My dream is, and I expect that this will happen, that up to 5 years, every patient will receive Kaftrio in Slovakia, because Kaftrio is good for maybe 90% of CF patients. So everybody who have 1 delta F508. In Slovakia we have around 330 patients, but there are still limitations by age. It's about 12 years, so we suppose 200. Yeah, but now it's from 12, so yes, maybe it's around 200 patients for Kaftrio in Slovakia. And also we have 1 patient on Kalideco, what was big fight with insurance company, but yes, it works. And this time there is 1 patient on Kalideco, 1 patient on Simkevi, and 2 patients on Kaftrio. But the truth is that both of the patients who now receive Kaftrio had to collect the money or pay by themselves. 1 patient paid this half a year, and the second patient paid 3 months of therapy. What the price is around 20,000 euro per month, you know. Orkambi is around 10,000, 11,000. So it's, how to say, it's so difficult to live with the feeling that there is some therapy for my children and I cannot buy it, because you have to be really millionaire to buy it. This is very sad, but I believe that it's still mirror, and I am in this field 33 years. It was so pessimistic and sad 33 years ago. But we can live this time when here is therapy. And yes, as you said, yes, I also want to go back 30 years and give this treatment to every patient also that time. So thank you for coming for this session. Now we have a coffee break, but it's short, so come back and we can continue in the we have there more about daily treatment, maybe more about all aspects, because really the cystic fibrosis is the whole medicine in one patient. So see you soon after 15 minutes. So I can propose that maybe everybody can say a few words. Who is it? And maybe why is here? And if you have some issues, just tell, and then we try to answer or tell what is interesting for you. I planned this session for this leaflet, which we prepared. It's about daily regime of CF patients, but we have 1 hour, so we can talk about what you like to listen. Okay? So maybe go this way.
I'm children's pulmonologist working in Lutsk in regional hospital, and I deal with little patients with CF. You recalled COVID, and I would like to share that one of my patients, 5-year-old patient, he survived COVID, and unfortunately his lung function has deteriorated, and basically all patients were fighting with COVID, and there were no problems with lungs. There were various multisystemic inflammations, but patient with the CF had fever, had breathing dysfunction, and it was at the beginning of the pandemic when there was scarce information, not enough information. Now we changed our treatment approach, but to be honest, I was really afraid how we would live through this, but our control measures, we saw that the fibrosis has worsened, and also we continued treating him. But for me, it was a very important experience, and this stage was very important because it was really at the beginning of the pandemic, and he was a heavy patient with CF and COVID combined. But basically, I read literature that in patients with CF, COVID never goes harder than in ordinary patients, because basically most kids kind of don't have any symptoms when having COVID. Like a pulmonologist, I know that in other patients there was bacterial pneumonia, but it was afterwards, after the acute process of COVID. It's like the 3rd week of the disease. It's about ordinary patients. That's what I wanted to share. And now I would like to ask about hyperproton pump. For how long do you prescribe this pump? Because we have some patients, we give them these pumps and we support their weight. And we see a clear correlation. Once we take away the hyperproton pump, the weight is being lost. But we cannot give it all the time. Of course, it all depends on nutrition. But I have 2 patients. Maybe there are some options like inhibitor, then run it 1, or maybe we should replace or change something. For how long should I do the pump, and what is in your practice?
In our practice, we have very nice gastroenterologist. And if I don't know something, or if I cannot decide it, I ask them, I send a patient there. But usually we used to give for 2-3 months, not more. And after that, they changed. They changed to some other. But really, such treatment for many, many years by gastroenterologists is done. About this COVID patient, of course, as everybody, we have also COVID patient with cystic fibrosis. But for me, it was a surprise we had no hospitalization with COVID, our CF patient. All were very nice and very good. And not worsening after COVID infection.
That's a very interesting issue, by the way. Moreover, we will discuss it more, I think. Your patient with CF and COVID, the 5-year-old child, he was in the hospital, right? When he got COVID. But as far as I understand, and as Anna has just said, there was no sharp aggravation of his breathing function. Yes, there was fever, and we can cope with that fever. For 2 weeks, the saturation decreased, and there was breathing insufficiency, and also antibacterial therapy was added. But we are interested what antibiotics you gave before and after. So he has a chronic bacterial infection, and he had tobramycin Proxon intravenously, big doses, and also ciprofloxacin in tablets for 3 weeks. Basically, CF kids do not take these antibiotics. We know that it should be given from 15, but ciprofloxacin, Miss Anna, do you prescribe it to little kids when it is desired, even on the first year of age, right?
I tried not to describe ciprofloxacin because the last a few years it was new guidelines for children to try to avoid quinolone because of side effect on genetic basis. It means I tried to avoid. If I have another possibility, I don't give. I used to, for chronic pseudomonas infection, I try to hospitalize this patient and to give another IV antibiotic. Only, and during first year, if somebody has chronic infection, it is not treatment for tablets or for something, or first 2-3 years. If child need antibiotics and had chronic infection, and if he need antibiotics, I hospitalized him. Of course, from time to time, I gave ciprofloxacin. For example, there are Christmas or New Year, and he's bad or she's bad, and they doesn't want to go to the hospital for a short time. I used, because it is only peroral antibiotic which is sensitive to pseudomonas. But a few years ago, we used too much quinolone. After that news from WHO, yes, WHO, from Central, that it was new Central, don't use again, not because of not because of the bones or because of cartilage, but because of some genetic mutation or something like that.
Can I ask you, do you use combination of antibiotics for cystic fibrosis patients? If you give them intravenous treatment, do you use a combination of 2 or 3?
Combination,
two, minimum 3. Two.
Two.
Yeah,
Two.
okay.
I also wanted to join this discussion about hinolones. We don't have such opportunities which you might have. And more often our patient can fail to come to the hospital. And more often we have cases when a patient asks or demands and, like put you in such circumstances that I need to urgently start treatment because when a patient comes, he will be in a much severe state. So ciprofloxacin is what we do use in an oral form. Now I often switch to 2-week courses, but when in the past it was 28 30-day courses. And if we have better opportunities, we will switch to something else. As for hospitalization, every time when there is exacerbation in kids with at the age of 1 year old, we have more, in our hospitals, we have more opportunities for patients to get infected. So we kind of postpone the first hospitalization as much as possible until I'm able to treat a child in the ambulatory service, and remotely I will use such a chance. In such case, I can see a patient once in 4 or 5 weeks to see how he or she responds to the therapy. I think that every country and every type of conditions and social and family conditions also make certain adjustments to how we treat patients, and the number of specialists who are dealing with the problem, we also have such a legal necessity to rest, to get trained at some conferences. And in such cases, the oral antibiotics actually kind of saving us, because when we leave our patients for a week, we can give them antibiotics perorally of second generation, because we know that it might provoke the resistance of the bacteria, and Folosperines are only used intravenously. And regarding the number of antibiotics at the same time, they can be 2, 3, or 4 of them at the same time. I can share what kind of combination we use. If there is Staphylococcus in Synagnica and there is a heavy patient, he will get dobromycin, meropenem, and ciprocinin. If there is MRSA in a patient, we have patients who even at the early children's age, not in breastfeeding age, but until the age of 3 years, they have MRSA, and linezolidine is also added for 2 weeks. And also we used 28, 30 days in the past, but since there are difficult problems with eyesight, then we use 2-week courses, and vancomycin inhalations also are quite helpful, because the latest recommendations enable us to eradicate MRSA and to treat chronic MRSA with 4-day inhalations or 2-day inhalations, 4 milligrams per gram, and this is quite tolerable by patients. Of course, ceftazidime inhalations is very also useful, but although it has bad smell, but the patients are satisfied, in quotes. But if there is a situation, I'm happy that in our center we don't have patients with sedation. Our laboratory identifies such patients, and take into account how often we do bacterial tests, we won't be able to do that. I'm concerned that we have patients more and more often with resistant Achromobacter. And I think this is one stem which arose of this bacteria, and he's in our hospital. So I think these points of the probability to be infected in the hospital, that's what restrains me from offering hospitalization. I try to avoid this, and our hospital requires reconstruction. It is understandable that our center is not the way we like it to be. Our patients are in separate wards, and there are also people with asthma, with bronchitis, 2 patients together, but mostly lately we have 1 person wards, and if there are 3 patients in a ward, he will be alone. So we try to basically not to let a patient out of the ward as much as possible, plus masks, hand washing, and social distance. You gave these bracelets to us. Thank you very much. And we had physicians who didn't understand why we identify patients with CF, but we said that they have to see each other at least. They do not need to know each other, but they will see that there is another CF patient. They will not communicate because if it's a little kid, the bracelet should be put by his or her mother, and the patient will see a patient. So if you have other bracelets like this, we will be very grateful because I already handed out all of them.
Да, можете нам дайте. Оль.
Не, от нас хто дав?
Контакт. Добре, дасте нам. Ну, отлично. Вот, супер. Вообще красота.
Okay. I want to speak again a little bit about quinolone, because we have every year a report in our hospital from microbiology where is written which kind of microbe we have in the hospital and how is sensitivity. And I remember last few years how was sensitivity to quinolone a few years ago. It was very nice sensitivity, and I remember that some of doctors, maybe also me, we used to give a lot of quinolone, not only for cystic fibrosis, but for also for other also for other chronic patients, for example, with very severe infection, with some hydrocephalus, with some another infection, not only lungs infection, but really for a bad patient. And after this few years, and we ask maybe as a first time, I don't want to say first time, but nearly first time choice, because it was really very nice and it was really very sensitive. After this a few years, our resistance increased too much. Now we have 30 to 40 other microbes resistant to quinolone. For that I am speaking about it, to take care and don't do the same as we did. To think that resistance will come if you use too much. If you use very often quinolone.
Now we are on the stage that we have sensitivity to quinolones, and sometimes only to quinolones, and actually we regulate our prescriptions regarding it. And in Ukraine, we don't register new antibiotics, although I, as a doctor, understand that this is not the solution, because we have new antibiotics and we will have resistance to them sooner or later. So I haven't seen resistance to linezolidine. And I think that there is a problem of dosage, because we prescribed the dosage of torhinolone 40 milligrams per kilogram, ciprofloxacin twice a day, explaining it to parents, specifying it to parents about the right way of doing it. Very often it happens the way that we prescribe it to the patient, and he goes to the other region. And when they start looking at our prescriptions, the doctors who are also experienced with good categories and good knowledge and skills, they start saying different, not really true for our patients information. And the patient starts doubting and stops complying with our recommendations, or does these recommendations not sufficiently. So we don't have the communication among doctors, and sometimes we have very specific doctors. And in the western region of Ukraine, we communicate, all of us, everyone knows CF and treats CF. But when there is a complicated case, we try to write about it or call each other to call at 8, 9, or 10 p.m. or answer at 10 p.m. and then till 12 speak about it. But there is the communication. And when I have some doctors from Kiev or Eastern Ukraine, Kherson, Odessa, where there is a huge CF center, when the patients come to get the treatment to us, and there the kind of fun starts. I have to say, don't listen to doctors who are not specialists in CF area, not because they are bad specialists, but because they don't know all the specifics of CF. Maybe this is not very colleague approach, but this is the only leverage which has to stop the patients, because the mother, no matter how educated she is, speaking different languages and having a few degrees, she is not a doctor, and she has the right to hesitate, doubt, and analyze, thinking about what will happen with the organs of my child, you see? And relatively, accordingly, there are some psychological aspects, and I am ready to contact, but when nobody calls me, I have so many things to do that I would do the things that I need to do. Dear colleagues, Lyudmila Yosipovna, I'd like to say that Anna cannot participate today in this concilium, but I offer this this way to discuss it, and then you can look at it. So the patient I spoke about before, the problem is the following. The child was born with the delay of the fetus development, with the incision, not natural birth, the parameters to 600 kilograms and 45 centimeters, borderline indicators for the child. The child is term born, and on the 32nd week of pregnancy, the ultrasound suspected the blockage of the gut. And when this child was, this woman, the mother, came to us, she received all the necessary examinations. She got the surgery. The patient got the surgery in terms of the blockage of the gut at the end of the first day. And the surgery identified that it was really thick meconium, then twisted gut in the wrong way, 360 degrees medial part, led the twist, and all of that for one child. The child had the surgery. There was no gut resection, but double ileostome was put, and paroxysmal ileostome is there for the feces to get out, and distally, where in the area of the thick gut, the parents, they are taught how to work with the stoma for it not to close. And we always hope for the improvement of the nutrition status, and the child will grow, and we will remove the blockage of the gut. This is something that we usually do all the time. Unfortunately, this child was discharged from the hospital at the age of a month and 10 days, 2 kilograms, 800 grams was discharged. Then she reached 3 kilograms 200. She received cryon of high dosage out of antibiotics. The child received peteracillin the first time, tazobactam. On top of that, mironem, carbapenems, something there. So the child was discharged with the recommendations of care and so on. After 27 days, the child was hospitalized with coughing, lung problems, and with the X-ray, there was pneumonia and other problems. Right now, the child continues getting the treatment. About 1 month, she's in the hospital, but about 10 days, so the second time, the first time mironem wasn't there, mironem amikocin, it was empirical. We didn't know the culturing results, so the culturing showed negative hemoculture and the content of bronchial tree wasn't in the culturing, but the child is fed through the tube and the content from the oral, from the mouth, and you know, when we speak about the tube, you know, serration, sensitive to cholestyne and citrofloxacin. And meanwhile, basically after 10 days of hospitalization, the condition deteriorates, hyperosthesia, the head goes back, pulsing on the back of the head, meningitis was suspected. There was leukocytosis, 61,000, 54,000. During the first combination, everything dropped to 22, but at the same time, neurological symptomatics was there. And when limbal punction was done, thank God, there was no meningitis. So we made conclusion of neurotoxicosis and the threat of generalization of infection. And, you know, 0.5 of local result, but with the septical complications, it was like that. And for 2 weeks, the child was on citrofloxacin IV. Colomycin receives the 3rd week. We decided to continue the treatment. It is allowed for the young age, such young age. And right now, the culturing shows bacteriology, shows Klebsiella, and also sensitive to polymyxin. And further, this week probably, she will receive colomycin, citrofloxacin we removed 2 weeks and so on, in IV immunoglobulin, antifungal products, crayons, and so on. And today, right now, the problem is the following. Firstly, we need to think about the antibiotic we can use in the future. That's the first question. The second question is the child 10,000 received 10,000 units, and right now it's stagnating. The child was getting the feeding through the tube and with the bag, tube and the bag. And the doctor before the conference called me and told me that, so the patient lost 100 grams at first, but the weight was 3.5, the blood, and I asked why. The child is more active, neurology is better, blood better. What's the problem? What is the tolerance? The tolerance is good, 90 for every feeding. So apart from the breast milk, which the mother pumps, and Nutrilon protein and Infatrinia Peptisorb, the child at first renewed the weight to 3.5 kilograms and then lost over the weekend. And when we started to understand why, turns out parents stopped feeding through the tube. So the child couldn't suck the necessary amount, although the tolerance is for much bigger amount, but like she can not possibly suck that necessary amount. And today I spoke with the doctor and she says that the child lost 100 grams more. So after 1 month, the child's weight is 3.3, 3.2 kilograms. And right now turns out that the parents stopped buying the formula. I can't tell you that they don't want to buy anything. Probably they are just exhausted because of this difficult situation and the fact that they've tried a lot and bought a lot. And maybe someone told them, someone maybe said, let it be the way it has to be. If the God gave the child, the God can take the child. Maybe the situation is like that, but out of the communication with the mother, it gave me the impression that as if the child was interested, the mother was interested to have the child alive. This is their first child. And given this situation and the competent people, Ludmila Josipivna and Anna, what would you recommend in terms of the antibiotics? So colistin, to continue colistin with the inhalation form if there is sensitivity. Okay, please ask the questions. I haven't seen this child for a few months either.
As I understand, this child is stable. This child is stable now. It is not after treatment with all these antibiotics, this child is stable. He is without any sign of infection, general infection or local infection. And she had good laboratory results. It means she doesn't need any IV treatment. Is it okay?
Значить, на сьогодні...
Or she is still under IV treatment?
На сьогодні...
For today, we decided to continue antibiotic treatment. She's colistin. She receives colistin, colomycin. Внутрішньовенно? Yes, IV. Because you understand that. The inflammation was really difficult. And we cannot in 2 weeks stop. Although hemogram became much better. Leukocytes went to 7.9. There was 61, 52 leukocytes, and it dropped to, there were 28 sticks and domylocyte, and so the formula more or less went back to normal. Я питаю, чи ще треба використовувати внутрішньовенні антибіотики? Well, that's why I'm consulting with you. Добре, добре.
So today, currently this patient for already a couple of weeks, 3 weeks, she's getting colomycin intravenously, just colomycin. We eliminated ciprofloxacin. But the question is how we should plan the antibiotic therapy further.
Usually we used to give, if this child is seriously ill, we used to give 3, not more than 4 weeks IV antibiotics. And after, if still we have some doubt or we still want to give some antibiotic to the child, it's a question if we cannot give antibiotic by inhalation. Yes, we used to give for inhalation antibiotics, and we can give, for example, for 6 weeks or 2 months more. Yes, this is first. And about this nutrition, if this child cannot suck, we used to give nasogastric tube and to feed by nasogastric tube. It must be adequate amount of the milk. And our parents teach in the hospital how to give this nasogastric tube. It is not also only for cystic fibrosis. We have a lot of patients with neurologic disorders, and there is for a long time, for long life, is feeding by nasogastric tube. I mean, it is not something what these parents could have a problem to do it. Yes. And if you want to improve this nutrition now, you can give him IV some proteins. You can give him some intralipid, some trace, some IV vitamins for example, 1 week to improve fastly, very rapid this nutrition. And after that to wait. And to feed this patient and to wait.
Thank you very much. Regarding the clinical picture, it's what I'm interested in. That the situation is that a patient with improvement after the surgery, he went home. You dismissed him. He went home for 20. He went to home for 2.5 weeks. Okay, what was at home? The question arises immediately. What exacerbated his state? If he returned with with pneumonia, that means that he has a reflux. Did he get the anti-reflux therapy? Another question is that you discharged a patient when we had a terrible heat. Did this patient get salt in addition? Because, for example, if he has, for various reasons, he had electrolytic problems, disorders, it can be a disastrous situation. When there is inflammation and low content of potassium, magnesium, and chlorides, it can cause a very severe state, and there will be a redistribution of liquids, and probably for that reason you had this problem with on his head, and there's no meningitis. So this encephalic reaction, it was neurotoxicosis, or there are electrolyte disorder. So I totally agree with Anna that parental nutrition is necessary with additives of lipids, amino acids. At such an age, I would give glucose intravenously, and also this triple medication, which Brown company sells. They have this combination of these additives. They have a combination of lipids and proteins and carbohydrates. But if he didn't get this anti-reflux therapy, he probably lost his weight. So the zone, this will be the only way to get nutrition. But it's very important to insert zoned in a proper way, not to put it in the stomach, because if it is in the stomach, it will be a provoking factor, and reflux will be due to an extraneous body in the stomach. If zoned is entered into the intestines, and also our specialists are affixing this intestine. Basically, through the zoned, the nutrition will be possible, but you will not be able, since the intestine has lesser volume, you'll have to give milk in drops, because otherwise you will provoke any other symptoms, heterogeneous symptoms. So basically, step by step, like with gastrostoma, the nutrition will go, we should go there inside the child gradually. And another question, what is with his belly? Does he have a big belly? Or since I'm a treating physician, I seen this child 2 weeks ago. I talked to her, I'm now on vacation. I saw him. It's just a little bit, no major problems with stomach, and he has good stool every day, or more or less good characteristics, yellow color, because he gets breast milk. And regarding antibiotic therapy, I also agree with Anna that now at this stage, in addition to inhalation antibiotic, this child does not require anything else. What about hemograms? Is normal. You need to repeat procalcitonin. It's a reactive protein. If you don't take it, you should add it. And also, I'm interested about cologramma. Yeah, we did cologram, and now I cannot say. Of course, we should do this. But as far as I understand, in this specific situation, it's the 3rd week. We can complete Lumicin intravenously, and then we give colomicin through inhalations, which is released. It goes for kids up to 8 months old every day, 2 times a day. You also said that this child was not just on zoned nutrition, but also had milk from bottles and didn't gain weight. Probably you're right that there was no anti-reflux therapy because, for example, what do you advise? Ultrasound? Metrazole? Omeprazole. I would also advise Cerucal, or perhaps Anna will add something, and I will look at his belly, whether it is swelling or not. Omeprazole. What is the dosage? The minimal? Also, the baby is little, not mature, immature birth, and the problems with intestines with such a long antibiotic therapy, there are surely problems with the gast. So there should be calprotectin therapy, and also we should understand whether there are no proteins that indicate some inflammation process in the gast. So I would also, if there is an inflammation, I would give some medications that normalize the flora in the gast. And also I'm interested in antifungine medications. What is the vein? What about the vein? We use a vein which is on the leg. We switch places for intravenous injections, and when there was a septic manifestations, we actually suspected that there was flea bite, but it seems like everything's okay. And altogether, antibiotics, we treated that. Everything kind of looks to be normalizing right now.
I have one more idea now. Which kind of formula did you give to this child? Because maybe it could be problem, for example, with allergy to cow protein. It maybe can be way to use some hydrolyzed aminokyselin, Neocate or Nutriol allergy care. I don't know from which one you have, which varies all this protein hydrolyzed. Or it is only amino acid. It can be also this.
the child gets his mother's breast milk and also peptisorb by Nutricia company. The only thing is that, as we have found out, despite our recommendations lately, they didn't give these protein medications in enough dosage. After the surgery, she had parenteral nutrition. In our she's continuing getting 1.5 milliliters of another medication, which is very good, through Zond. Regarding lipids and proteins, we have a program which calculates all the numbers, and she gets enough per kilograms of weight. So we raised this question that if she doesn't eat enough meals, this means that she doesn't get enough proteins, but we need to ensure that anti-reflux medications would be given in order to eliminate this liquid redistribution. Also, I have another question. In our protocol, we have such a point as bisiptol. Can we also add? I have quite a big concern about this patient because cobamycin inhalation, only this medication inhalation would not be enough. But because I don't know how they will treat a child at home, and probably bisiptol will be also prescribed. What do you think? Because even when there is immune deficiency, what should we give? I think that if we use oral antibiotic, it will be okay. It will be more efficient. In addition, you need to agree with the parents to see the child once in 5 days, even if they live on the highest mountain in the Ivano-Frankivsk region. I apologize for being late regarding this little patient. And regarding her parents, there are no, not even a thought that they do not perform something, because these parents and the grandmother, they are advising me, they're consulting with me from the very beginning. So we need to look for something else. They are complying with everything, with all the basic recommendations from the very beginning. Prescriptions should have been done from the beginning, and just that this child, she already got this disability status. Yes, but we need certain documents to be validated. But what patients should do before that, and parents also? For me, I know a lot about this family. And to be honest, I'm disappointed in this situation. I'm not the lead doctor for this child. There is another physician who is the treating physician of this child. And today she said that the parents on this weekend, they took her away from the zoned nutrition, and this means that she doesn't get enough food, and if she doesn't get enough food, she doesn't have energy, and it's just very tough. These are quite polite people. They are delicate. They execute everything, but I don't know what happened over this weekend, why they stopped using Zond, but this is already lasting for quite a long time. When they miss one meals, it might severely affect the child. If the meals are fine, nutrition is fine, it's very important to prescribe everything for the parents how to feed the child, how to use dosage, how to take the crayon, because they are wonderful parents. They never addressed me so much as they did, and they were looking for assistance. They wanted to get the right dosage, because in my opinion, since my child is already 17 years old, I observed that not everything was done correctly, and probably we lost some time for this particular child.
I am very sorry, but we have to stop this discussion because we have to continue and we need to prepare the room for next session. But I am very happy and thank you for this discussion, this consultation, where we can see how many details and complications are around cystic fibrosis patients. One, what I can say, that it's very important to have teamwork, and CF center mean that there is CF team, multidisciplinary team of specialists who take care about not only CF child or adult, but this team take care about whole family. And one of the most important thing is that they have to communicate between specialists, but communicate also with parents, because the basic team for CF patients is physician, pulmonologist, gastroenterologist, physiotherapist, nutritionist, psychologist, social worker. This is the basic team. And around them are ORL, anesthesiology, gynecology, I don't know, the whole medicine. CF is very specific disease because it includes the whole medicine, all aspects of our bodies. So, and one of the everybody, I don't know specialization, which is not necessary for CF. So, but one of the member of CF team is always the parent. He is on the same level as other ones. So it's really good to maybe, this is not usual in our socialistic, or we are not work this way for all our lives. So everybody need to do some changes that the mind, and this list of daily regime of CF patients, this is just, you know, list of all activities, proposal. Everybody have to create his individual plan. And what I want to say? Sorry. So yes, the truth is that we can have expensive drugs for CF patients, but if the parents will be not educated and will be not communicated again and again and again, all money flow away, because then they are not able to do all these activities every day, whole life, never-ending story. And you can see this long list of everyday therapies. And on the other side, the CF children and CF young people, adult people, they just want to live normal life as other ones. So I will stop at this moment. Thank you very much for talking, doing everything. We need to prepare the space. We have last 2 hours presentation and maybe some time for discussion, and then the last coffee break, which will be not now, but after the presentations, okay? Thank you. Maybe, yeah. Now we continue in 5 minutes.
Dear colleagues, okay, we continue. the work of our workshop. And now we have the final session. We will start from Anna Feiketova, who will speak on behalf of Košice, the University Hospital of Košice, where patients get treatment, consultation, supervision. Children get the service with CF. She's pulmonologist, allergologist, pediatrician, so really experienced doctor. The topic of the presentation, COVID-19 and CF, very actual topic. Please, Anna, the floor is yours.
Hello. Hello, everybody. Good afternoon, everybody. When I choose my presentation for this conference, still I don't know what to choose. And I was thinking about COVID-19, but I was afraid maybe everybody is speaking about COVID-19. Last year it was the most frequent word everywhere, and maybe this year it is also still COVID-19 and vaccination. Maybe more vaccinations than COVID-19, but I want to speak a little bit about CF and COVID-19 and how it was experienced in Europe and how it was experienced with COVID-19 in cystic fibrosis patient. Here is my declaration of interest, conflict of interest. From the beginning, it was many people speaking, maybe it is not epidemic, maybe it is just a fiction or something like that. And I look for some definition. And pandemic is a large-scale epidemic that spread over a geographically large area. COVID-19 is caused by a new severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2. Now more than 220 affected country. It is from the last World Meteor Info from 5th July. More than 184 million infected cases. Around 4 million confirmed deaths and more than 170 million recovered, which is very nice news. Pandemic were, we know from the history, a lot of pandemic from the 14th century, for example, when it was a black plague. Spanish flu, it was beginning of last 20th century. It was 40 to 50 million people were affected. And in 21st century, it is COVID-19 pandemic. This is the last distribution in the world. This blue one is Europe, and this green one is Asia. Up is a distribution of cases, and down, the second one is distribution of death. From the last year, from the January of 210 up till last a few weeks. From the beginning, we didn't know too much about COVID-19, and we were afraid. And I know in Košice it was maybe 1 or 2 cases, and everybody were speaking about, because In some other country, it was really a very bad situation, but after a few weeks or a few months, it came also to Slovakia. And now everybody knows that symptoms of early stage of the disease are not specific. It is cough, fever, dyspnea, pneumonia, it's a severe acute respiratory syndrome. It can be also other infectious disease, especially respiratory, other viruses as RSV, influenza, human metapneumovirus, adenovirus, or also also other diseases which are not infection, as vasculitis or dermatomyositis, it looks like. Now we have very nice diagnostic procedures as rapid antigen detection and real-time PCR. Everybody know in our country we do it for medical staff every 2 weeks until maybe we finish last month on May. We finish this regularly checkup in our hospital for all medical staff. Of course, it need not to be only COVID-19. It can be normal cold or it can be allergy. Both this disease looks similar, and it is one of the one of the leaflet how to distinguish very quickly because between these diseases. For example, from the beginning, COVID-19 symptom begins within 14 days of exposure. Can be less, but usually not more than 14. Usually at the fifth days becomes symptomatic person. From the beginning, many people compare this COVID-19 to influenza. Influenza morbidity and mortality is about 5 to 10% of adults and 20 to 30% of children each year, and worldwide 3 to 5 million cases are seriously ill every year, and around 300,000 to 600,000 deaths due to respiratory failure with seasonal influenza. And at that time, we were very, very scared about this disease. And we compare, for example, we compare this disease to another pandemic. It was special flu. In 2009, it was new influenza, H1N1, influenza A virus. And we remember that on that time, children and young people was also involved, and we have some pregnant women with very serious cases. And what this was a statistic about cystic fibrosis on that time. We know about 110 cases in literature. Median age was 13. 53% treated with IV antibiotics, and 48% people with cystic fibrosis has to be hospitalized, and it was 2.7% death. I remember also one adult patient with cystic fibrosis died during this pandemic. Why we are so afraid about cystic fibrosis? I mean, our patients know and they scare. Maybe I don't know who scare more, me or our patient, because his cystic fibrosis is primarily a lung disease with chronic lungs infection, and many patients with cystic fibrosis have bronchiectasis. They are malnourished. It means they are secondary immunodeficiency. And COVID-19 is predominantly most lung disease with very severe pneumonia, with acute respiratory distress syndrome. On X-ray is typically ground glass opacity. It goes to very fast, maybe in some patients, maybe our adults pulmonologists know more about it because I haven't seen so rapid and bad patient with COVID-19. That patient failed and died during 1 or 2 days after admission, or even hours after admission to the hospital, because it induced a lot of organ dysfunction and failure. And we were very happy with this one news from Italy, which was one of the first country where was a very bad situation with COVID-19. And we see that these results with cystic fibrosis was very nice. It was not one death on that time according to general population. It was published, and it was really very good news for us. After that, it was published many articles about it, that for example, this first one, it was multinational cohort observation study. Incidence of COVID-19 in cystic fibrosis was 0.07 compared to 0.15 in general population. It means our patient had less frequent disease and as other population. On that time started a project, COVID-CF project in Europe. This is last results I borrow from European Cystic Fibrosis Society. You see that in this project was involved 30 countries with cases. Around 1,500 cases were reported, and only 17 patients died, and more than 1,000 patients were recovered. It was half and half male and female, and it's interesting that a lot of these patients, maybe big amount of patients were adults. It was not children, and severity of this disease, around half patients were mild, asymptomatic, and only a few patients was severe and critical cases. It is from all this information is from all Europe, and also we gave our patient to this project, and it is still updated until now. You see this patient. It was, for example, 50 patients more than 50 years old, yes, and how was their pulmonary function? More than 70% patient. More than 70% FeO1 had very good pulmonary function. General symptoms was in most patients pulmonary symptom too, but it was also a few patients asymptomatic, and some of them has gastrointestinal symptoms. It is similar than general population. Severity of disease, mild disease, a lot of patients. What about treatment for this patient? Additional oral antibiotics, a few patients, additional IV antibiotics. You see immunomodulator, systemic steroid, azithromycin. Maybe they had no before, and vitamins, antiviral, antifungal, and antimalaric. In some country, it is in a protocol against COVID-19. What about complication? Few patient has pulmonary exacerbation, some bacterial pneumonia, and only a few sepsis or acute respiratory distress syndrome. And this results is a lot of patients, more than 1,000 recovered. And what about mortality? The mortality in non-transplant population was 1.8 to 3%, and higher was in transplant population, 7.3 to 13%. A few, this one slide about vaccination. Maybe your patient also are asking every day about this vaccination. Shall we vaccine or not? Do we have to vaccine or not? What is contraindication? Can I be vaccinated because I have this problem, that problem, and like this? This last data from 5th July, nearly 24% of the world population has received at least one dose of COVID-19 vaccine, but only 1% of people in low-income countries have received at least one dose. Which is really, there are countries with very nice vaccination rate at the United Arab Emirates or Israel or United Kingdom. You know that in some country, for example, in Israel, they are speaking about third dose of vaccine. And there are a lot of countries where they have not anyone. Factors that can mitigate COVID-19 in cystic fibrosis. Why it is like this, that that cystic fibrosis is not so bad as we were expected from the beginning, because there is a lot of preventive prevention, social distance, and self-isolation. Is it usual for cystic fibrosis? Also, to wear a mask is usual for cystic fibrosis, and frequent hand hygiene is for everybody of us very usual and very common. Also, our patients are younger. You know that age is the most important issue for very bad very bad disease. It means all other, for example, tick secretion in the respiratory tract seems to be protective for our patient. Also, they have some existing microbiota, and their body is trained to fight with infection. It looks also like protective factors. Also, they use some therapy, preventive therapy, which was also treatment for COVID-19, as azithromycin or high dose of D vitamin, which is very important. We were speaking about it today. It means there are some risk for cystic fibrosis patient, but this also disease as a protection factors. They are no obese, because it is also very risky factors for this disease, as there are no smokers, of course. We are taking care about 40 patients in our center, pediatric patients in our center in Košice, and 4 of them had COVID-19. They were from age 2.5 up to 14. None of them were hospitalized. All had a mild course of the disease. And what about therapy? 3 patients received more antibiotics, azithromycin and cefixime. All these antibiotics they receive orally. increased dose of vitamin D, C, zinc, and selenium. We add N-acetylcysteine and, of course, antipyretic drugs, paracetamol. You know that we try, and everybody of us try to do some telemedicine. It is very, let's say, primitive telemedicine. We just can have our phone call, but some of us use also email. No of this patient, these 4 patients, had personal visit. All of the visit was by phone. They did not come. They were afraid to come to the hospital, even outpatient, for checkup. And we hope then we start to learn how to do this telemedicine and how to communicate with our patient, not personally, but online. I don't like it too, but we have to do it, and we don't know what the future will bring us. This is I like this slide because it is pretty clear. As a pre-visit process, screen patient for pulmonary symptoms and try to ask for capabilities, if this patient is stable or not. If it's stable, okay. Do they have any technology? Do they have access to, they have a Wi-Fi, or they have a phone and they have some mail? Or if they are not stable, if they're acute, first of all, we screen them for COVID-19. If they have no COVID-19 and they are acute, they go to normal clinic, to normal department. If they have, of course, COVID, they in our Košice, in our hospitals, they go to infectology, pediatric infectology department. This is one of the results, of course not our, but I found in one article how these people and how our patient or this patient were satisfied with this new modality of healthcare, and also adults and children. They have very high level of satisfaction. They found that they have enough time to ask, they have enough time to speak, and they really like this telemedicine. I want to invite you to Košice this last week, Košice, in very nice summer days, to drink a coffee.
Thank you very much, dear Mrs. Anna, for such a wonderful presentation. It is very topical for our time. We are now just, let's introduce another speaker. I would also like to thank Mrs. Anna because it's very interesting speech, and it's very interesting that it's a topical and very urgent for every country. Indeed. Now I would like to give the floor to Hugo Rocher. For several days, we already been observing your incessant labor and industrious labor with your patients, but now we would like to hear your speech about chest physiotherapy.
Thank you. Oh, thank you. Thank you very much for your invitation. And today I present to you our clinical experience in chest physiotherapy in COVID-19 in France. You know that I am a physiotherapist and I work in a rehabilitation center, and I am a member of the respiratory physiotherapy group for the French Language Society of Ophthalmology, and I am a member of IPGCF, International Physio Group for CF. And I have been contacting that year for to organize courses for physiotherapists in COVID. It was extremely new, and we have to collect a lot of informations all around the world, and all the lectures and all the publications, and to try to be as most effective and efficient possible. And Claire is one of my colleagues who is graduated to a master research in physiotherapy. While 180 million cases of COVID have been identified worldwide, and over 5.82 million in France, not a single one of my patients with CF has had COVID. And we think that it's a question of hygiene. They used to be very proudly and very, yes, and they preserve their hygiene. I think it's a very good lesson of our CF patients to other patients. On the other hand, we have taken care a large number of patients released from intensive care and of COVID long patients who in recent months have required physiotherapy treatment. COVID is an inflammatory polysystemic disease, as I say, Anna, characterized by fever, cough, and dyspnea, but other symptoms condition our treatment, such as myalgia and chest pain and fatigue. Our patients are rarely a fatigue syndrome. I am therefore going to present to you the case of a patient whose journey is very representative of what physiotherapy can bring to this type of patient. So, this patient is 59 years old. He's doctor. His height is 177 centimeters, weight 90 kilo, loss of 10 kilo since leaving the intensive care unit. Sports and leisure, hiking, mountain biking, travel. History and comorbidities, asthma, spastic bronchitis, C6 and C7 herniated disc operated in 2019. On the chest CT scan, frosted glass areas and linear condensation in the lower regions are found. Extensive SARS-CoV-2 attack 25 to 50%. On the 2 of January of this year, first symptoms are cough, asthenia, and diarrhea. On the 3 of January, he did a PCR test which came back positive. On 7 of January, he was urgently hospitalized for acute dyspnea. 5 days later, he is in acute respiratory failure with bronchial hyperirritability. He is therefore transferred to intensive care, where he is treated with oxygen therapy, bronchodilator, and antibiotic. He remained 13 days in intensive care, and on the 25 of January, the evolution being favorable, he was transferred to a follow-up care service for treatment, which lasted 14 days. Repeated dyspneic exhausting cough limited reconditioning to exercise. This is why he is referred to us out of center specializing in respiratory rehabilitation, the CKRF in Marc-en-Barœul. He arrives in a wheelchair. He arrives in wheelchair, accompanied by a member of his family at the office. The patient is very anxious. He describes his sleeps and his appetite as bad. The hydration is good, morale is average, and the patient doesn't smoke. As with all our patients with respiratory pathology, we are interested in the quality of its respiratory pump, which means taking charge of the lung, but also of its envelope, its external mechanics. We have kept the patient for 1 month regarding the morphostatic and morphodynamic assessment. In 8th of February, we had a finger to ground distance of 10 centimeters, left tilt 56 centimeters, and right 48 centimeters. A month later, we had gained 7 centimeters in flexion, 5 centimeters in left, and 7 centimeters in right tilt. As for the acromion table distance, showing the forward curl of the shoulders, this is 10 centimeters. This was 10 centimeters, and was reduced to 7. The thoracic ampliation, showing the importance of his distension, the differential was 3 centimeters. It increased to 6 centimeters. Regarding the abdominal perimeter, he went to 106 centimeters to 90, and he also improved his quadriceps and biceps perimetry because it went for one from 48 to 50 and for the other from 30 to 32. As you can see from this slide, the respiratory work-up shows a significant improvement of it's here. A significant improvement of his spirometry as he improved his first vital capacity. His FEV1 went from 1.92 liters to 2.41, and he also improved his proximal and distal flow rates. His inspiratory capacity improved significantly from 250 milliliters to 1,750 milliliters. The secretions, which were of the mucoid tape, according to the sputum color chart, returned to a normal appearance. Cough education and respiratory physiotherapy significantly reduced his dry, irritating, and tiring cough. His cough was no longer dyspneic. As for the muscular and functional assessment, his 3-minute test, chairlift test, which was scored at 40, signifying a clear deconditioning, rose to 78. As for the 6-minute walk test, the distance covered increased from 210 meters to 327 meters, with a decrease in dyspnea, an improvement in oxygen saturation, and a decrease in heart rate. On the other hand, fatigue remains rate at 3 out of 10. The objectives of the treatment were to decrease anxiety, inhibit and control coughing, to do a therapeutic education, increase thoracic and spinal mobility, muscle strength and endurance, recondition the patient with effort, free the airways, increase lung capacity, all this while respecting his weakness, his fatigability. It was not about muscle building, but about reconditioning with effort. To obtain these results, what were the modalities of its personalized program? 4 weeks minimum. The patient was seen at least 3 times a week. The session lasted between 1 hour and 2 hours. For each objective, an adapted therapeutic arsenal. Decrease anxiety, manage cough through relaxation, ventilation, education, massage, listening, and empathy. Taking into account the pain and managing it contributes the patient adherence to his treatment. This is no retraining possible without nutrition, hydration, elimination of air contaminants, and nose wash, of course, as we used to do with our CF patients. The experience with CF patients is a great experience for all kinds of patients who suffer from respiratory disease. The large volume of nose wash and gives this essential organ back all of its functions, including the major ones, airflow regulation. Restoring mobility at the pump essentially means working on rotations because the muscle fibers are more sensitive to it, and they are synchronized with the ventilation mode. Filling, emptying, stretching. The stretches are done slowly and gently because resuming too intensive physical activity would seem to decrease immunity. And we must take these recent studies into account in our management. The same is true for muscular work that we have proposed in strength and endurance of all the peripheral musculature, but also of posture in a work of repetitions and progressive loads. As for exercise, reconditioning, it's performed under oxygen first, in a seated position, on an ergometric bicycle, then on a treadmill, then on a rower, depending on the stress and the ventilatory threshold. The freedom of the upper and lower airways determines the quality of ventilation and oxygenation. It's a prerequisite for reconditioning. Autogenous drainage is obviously retained as the reference technique without adverse effects and contraindications. It's particularly suited for weak patients. It can be supported by the use of positive expiratory pressures. The patient presented here has benefited from a new technology, CMOX, which aims to break down mucus and which seems to have given promising results in reducing chest distensions to reduce residual capacity. Visualizing the recovery of inspiratory capacity is extremely motivating for the patient and is one of the major elements of a successful rehabilitation. For this, we use incentive spirometry devices with a volumetric and flowmetric aims. Patients who have had COVID without hospitalization complain of persistent symptoms, sometimes 3 months after infection, sometimes even longer. We have in our center now patients who arrived after 6 months, near 1 year, with symptoms of fatigue and deconditioning. The most common symptoms are fatigue, shortness of breath, or respiratory discomfort, pain, and cardiovascular problems. Among the causes, systemic inflammation, autoimmune reaction, impairment of the functioning of certain areas of the brain. Many of the post-COVID-19 patients show symptoms of hyperventilation syndrome. The cerebral respiratory centers are out of order under the effect of significant psychological, physiological stress, which can lead to shortness of breath. Finally, some patients develop a chronic fatigue syndrome characterized by great fatigue and post-exercise discomfort. The care must be multidisciplinary. Cardiologist, pulmonologist, psychologist, physiotherapists, etc. Our patient has now resumed his professional activity. He had to significantly reduce his daily activity in view of the persistence of certain symptoms. He maintains a regular physical activity and, as a doctor, has realized the importance of physiotherapy that he has admitted to knowing little about. Convinced today of its effectiveness, he told us that he would prescribe it to benefit most of his patients. Our team, specializing in respiratory rehabilitation, learns every day from the patients it supports, continues to train, to question themselves in order to become more efficient. Because patients with COVID see their ability to concentrate and focus diminishing, I thank you very much for your attention. Thank you.
Thank you very much for your beautiful speech. We are admiring your professionalism and your knowledge, and the fact that you're selflessly sharing your knowledge and your wonderful professional subtleties with our specialists, with our parents, and generally you ignite us with your activity, enthusiasm, and bioenergy, which is so positively coming from you. Let me ask you little questions so we understand that your team is dealing with rehabilitation of kinesiotherapy, physiotherapy, with all respiratory disorders, including chronic disorders and post-COVID disorders. The patient whom you presented, our colleague doctor, after getting the course of treatment in your rehabilitation center, you said that spirometry has improved, but what about the X-ray studies? For how long the changes in his lungs continued? Do you have any information about that and about other patients who got your services and those who did not receive your services? Is there any difference on X-ray data and on other computer records after physiotherapeutic methods you apply? Question number one is that we understand that you deal with physiotherapy, kinesiotherapy, and such types of rehabilitation after respiratory diseases, including COVID, right? As far as I understand, your team is dealing with respiratory pathologies, including chronic pathologies, including the and a big part of patients with COVID.
Non, en fait, je vais parler français et tu fais la traduction. D'accord?
Прошу? Да, отлично, все підходить.
Merci. En fait, la réhabilitation respiratoire est un concept qui n'est pas nouveau, qui est maintenant développé dans le monde et qui est scientifiquement prouvé. Il est de grade A. La Cochrane a recommandé l'année dernière de ne plus publier sur la réhabilitation parce qu'elle avait fait la preuve de son efficacité parfois même, notamment dans la BPCO,
навіть з пацієнтами, у яких є хронічне обструктивне
avec des bénéfices supérieurs aux médicaments.
вищий позитив від ліків.
Elle comprend une prise en charge multidisciplinaire
Вони розуміють, що потрібен мультидисциплінарний підхід
avec un bilan pneumologique
з висновками пульмонолога,
et puis un traitement stable
лікуванням стабільним лікуванням
et une prise en charge intensive en physiothérapie.
і інтенсивним заняттям фізіотерапією.
La clé du succès est la motivation du patient.
Мотивація пацієнта.
Et cette prise en charge,
Це коли ми займаємося пацієнтом,
qui aujourd'hui est extrêmement documentée,
яке сьогодні це все дуже так потужно документується, задокументовується,
elle prend le patient à un moment donné de sa maladie
і пацієнта починається займатися в певний визначений момент,
et nous devons amener le patient à changer de comportement.
і ми повинні привести до того, щоб у пацієнта змінилася поведінка, щоб пацієнт змінив поведінку.
C'est un peu comme dans la mucoviscidose.
Наприклад, як у муковісцидозі,
Il faut que le patient décide lui-même
треба, щоб пацієнт при муковісцидозі вирішив сам,
qu'il a la maturité et l'âge pour se prendre en charge
що він вже доріс до того, що він почав собою займатися,
et il gagne en adhérence et en compliance au traitement.
і він почав розуміти необхідність використання лікування.
C'est là où toute l'équipe médicale doit parler le même langage.
Саме тому будь-яка медична команда в цьому випадку повинна говорити однією медичною мовою.
Parce que souvent le patient est perdu
Тому що дуже часто пацієнта втрачають,
quand il entend des choses différentes.
коли він чує різні речі,
Et aujourd'hui, j'étais très heureux de partager avec Mathilde et mes confrères
Сьогодні я був дуже радий, що зміг розділити
le même langage et la même motivation.
з Матільдою і колегами ту ж саму мову і ту ж саму мотивацію.
Dans la réhabilitation respiratoire,
Дихальні
c'est la
реабілітації,
dynamique de l'équipe
це динамічність команди
et la volonté de gagner
і бажання перемогти,
qui fait le succès,
яке робить успіх.
parce que aucun patient insuffisant respiratoire
Будь-який пацієнт з дихальною недостатністю
ne rêve de faire des efforts.
не мріє, щоб якісь зробити, мріє, щоб зробити
C'est
зусилля.
c'est très difficile à vendre.
Це дуже важко це таке досягти.
Par contre, leur redonner du muscle,
Робота м'язів,
leur redonner de la mobilité,
відновлення роботи, відновлення рухливості,
leur redonner le plaisir de respirer,
відновлення бажання, задоволення від дихання.
leur faire prendre conscience des bénéfices qu'ils ont des traitements qu'ont donnés les pneumologues,
Вони завдяки цьому зрозуміють те, що до них хочуть і пульмонологи донести.
les met dans un cercle vertueux.
І це такі буде якесь коло поки що замкнуте.
Et les patients que nous traitons,
Пацієнти, яких ми
et Mathilde peut en témoigner parce qu'elle en suit beaucoup de Covid comme moi,
Матільда і я також мали Матільда і я також багато слідкуємо за розвитком коронавірусного захворювання.
nous intéresse nous en physiothérapie parce que nous ne traitons,
Цікавимося фізіотерапією, тому що ми лікуємо.
nous ne traitons pas des maladies, nous traitons des symptômes.
Ми лікуємо не хворобу, ми лікуємо симптоми.
Donc nous n'avons pas de médicaments nous pour ça.
Ми не маємо медикаментів для нас.
Nous devons faire un examen clinique
Ми повинні провести клінічний огляд.
extrêmement personnalisé.
Він максимально повинен бути персоналізований.
Et ce docteur qui a demandé à être suivi chez nous,
Який ось цей пан лікар, який попросив, щоб його лікували в центрі пана Юго,
avait quitté l'hôpital
госпіталь, його центр пана Юго,
parce qu'à l'hôpital, il toussait tout le temps.
він залишив госпіталь, тому що в госпіталі він постійно кашляв.
Qu'il n'arrivait pas à gérer cette toux épuisante, dyspnéisante,
Він не міг керувати
irritative.
таким кашлем, який постійно його подрязнював, коли було ще дискомфорт.
Aucun effort n'était possible.
І він ніяко ще не міг тоді зробити, здійснити ніякого зусилля.
Mais il avait l'esprit,
Але в нього є розум,
il était épuisé,
хоча він був і вичерпаний, виснажений,
il avait perdu 10 kilos
втратив 10 кілограм
et il est arrivé en chaise roulante.
і приїхав на кріслі колісному.
La priorité pour nous, c'était la gestion de sa toux.
Пріоритетом для нас це було керування його кашлем.
Et quand il a pu maîtriser sa toux,
І коли він зміг керувати своїм кашлем,
il a pris confiance dans sa rééducation.
він зрозумів необхідність своєї реабілітації.
Il m'a envoyé un message hier
Вчора мені надіслав він повідомлення,
pour me dire que son scanner s'était amélioré,
щоб його рентген покращився.
mais qu'il regrette
Рентгенологічне зображення
il regrette de ne pas avoir fait plus longtemps la réhabilitation
Він жалкував про те, що ще раніше не почав
parce qu'il pense qu'il aurait pu gagner plus encore.
тому що він думав, що він якби раніше ще почав, ще б більше виграв.
En conclusion, la réhabilitation,
Реабілітація це щоб завершити, провести, зробити висновок.
ça ne doit pas s'arrêter.
Вона ніколи не повинна зупинятися.
On perd 50% du bénéfice
Втрачаємо близько 50% позитиву.
si dans le mois qu'on a suivi un stage, on arrête de faire des exercices.
Якщо ми просто перестанемо, наприклад, протягом місяця робити якісь вправи.
Et si on ne change pas de comportement,
Якщо ми не змінимо поведінку,
au bout de 3 mois, on peut avoir tout perdu.
і якщо ми не змінимо поведінку, за 3 місяці ми можемо, що просто буде, що ми все втратимо.
C'est donc l'exemple même de l'interdisciplinarité et de la multidisciplinarité.
Це є також приклад мультидисциплінарного підходу.
Et encore une fois, ça, c'est ma conclusion. Ce sont les patients CF,
З муковісцидозу.
et il y en a ici. Ce sont eux qui nous ont appris notre métier,
Це саме вони нас навчили нашої професії.
et maintenant on peut en faire profiter d'autres pathologies.
І ми тепер можемо
Thank you very much again for your substantial and comprehensive answer and accents on all the issues of rehabilitation and physiotherapy. This is another comprehensive and systemic reminder to us from dear Hugo Gaucher. We thank you very much. And I also would like to emphasize that indeed our patients with CF, thanks to the fact that they are already learned in hygiene, in keeping social distance, and in actually in isolating from each other and from other people. Basically, they have certain advantage during the pandemic, and that's what Mr. Gaucher and Mrs. Anna have shown, that indeed cleanness and there is no such a big frequency of cases of COVID among CF patients, neither in Slovakia nor in France. And the next speech is our dear Katerina Stepankova. It's nano tissue from cystic fibrosis and how to use it. We kindly invite our dear esteemed Katerina Stepankova to speak. The speech about nanofibers.
To je začiatok. Tak. Unfortunately, the people from this company cannot come personally on this meeting. So, but they send you a lot of greetings, and they also sent you these 2 masks who everybody received in the conference bag. And they asked me if I can do the presentation. So I am not expert in this, so I just show you the presentation, read the text, and I believe that it will be clear for you, or you receive some information. I can say that this company supports CF patients in many countries by their masks and different kind of products which help to prevent not only COVID, but also other bugs which CF patients are danger for them. So Respilon is a Czech company operating on the international market, which has been engaged in research and development of nanofiber products since 2013, so many years before COVID. And our mission at Respilon is to make innovative use of the specific properties of nanofibers for a better and healthier life. A nanofiber was created at the beginning of the 21st century at Czech universities, and it soon became an effective weapon in the fight against the three most common dangers of today's world: airborne diseases, polluted air, and allergens. Nanofiber technology has superior properties that make it valuable for almost unlimited number of applications. We help to show how this new technology can be used in products consumers use every day. Nanofiber membranes contain an extremely dense network of fibers that are 1,000 times smaller in diameter than a human hair. These fibers are extremely strong and form a durable structure. The combination of these features can stop even the smallest solid and liquid particles. At Respilon, we believe we will never stop exploring new ways to improve products using the latest nanofiber technology. We have many achievements in the medical industry, textile industry, and we know it is possible to solve many different filtrations issues with nanofiber technology. Our products are designed to provide consumers with better air quality for the life they live. Our products are made easy to use so that your most important breath isn't left to chance. Just because of technology advances and allows us to provide you with superior products for your safety doesn't mean it should be complicated or difficult to use. Your health is important to us, and we work hard to make the products we offer as affordable. Respilon has branches in Spain. Respilon has branches in Spain, China, USA. We collaborate with manufacturers of top nanofibers around the world, with research institutes and universities. Respilon has its production in the so-called clean rooms in the Brno Technology Park, and also proven partners in several markets, which allow it to cover international demand. And here are the different kind of products which you can find on their website and buy if you like them. And I think that many people like because they are easy, very pleasant for breathing and give really big protection. In our current portfolio, we have nanofiber respiratory protection products, extremely light RespiPro and RespiRaptor respirators that find perfectly on the face, and Reshield neck gaiter, nanofiber window screens and door screens, nanofiber functional membranes for sports and outdoor clothing. In November 2020, we introduced our latest innovation, self-sterilizing VK RespiPro respirators enriched with a layer of accelerated copper. So these are different kind of their products, different colors. And this is this brown one, which is with this copper. And the nanofiber membrane mechanically captures viruses. Then the layer of accelerated copper kills them. The VK respirator can be considered the first product of this type, which offers repeated and long-term use, assuming you use the respirator for 5 to 6 hours a day. It will last for approximately 1 week. In other words, the cumulative time of use is 30 hours. Thanks to the deactivation of viruses, there is no risk of their future multiplication in the filter. You can hardly feel the respirator on your face because it weighs only 3.7 grams and its shape fits very well. Unlike ordinary face mask or respirators, when you are wearing in the level of the VK RespiPro filtration efficiency is not decreased by the humidity of human breath. It is patented Israeli technology developed by a scientific team led by Jeff Gabay, who has been working on these issues for decades and owns 35 patents. Effective and rapid virus deactivation was confirmed by testing carried out by renowned American laboratory Nelson Labs. All of our products are technologically advanced over time, and we implement changes based on the needs of our clients. In May this year, we launched the second generation of the VKRS people respirator. The second generation has been round ear lobes that features excellent elasticity. I think it's this one. Our portfolio also includes VKRSP Raptor self-sterilizing, this is Raptor, self-sterilizing respirator. VKRSP Raptor is available in the fish-type shape, thanks to which it does not move during speaking, which makes it the ideal choice for people who need to communicate and make sure they are easy to understand. This respirator fits well to people with a broader face and is suitable also for men with a beard or people with glasses. And this is a very special product. We launched Air Shield in 2018. It was the result of the feedback from our clients' patients who had to wear a respiratory protection in public, which was still quite unusual and was evoking a lot of emotions. Therefore, we came up with an idea. We hit our nanofiber face mask that very efficiently captures viruses, bacteria, and other harmful substances in a fabric scarf. And so we enabled those people to so-called blend into the crowd. That's cool and functional, and it can solve their situation. The Respilon nanofiber membrane is a part of each Air Shield neck gaiter. It is so sewn in the area of a person's nose and mouth. This membrane consists of an extremely dense net of nanofibers. Thanks to this combination, the membrane can mechanically block out even the smallest solid and liquid particles. Moreover, the membrane works in both directions. Our company is a long-term partner of Czech Cystic Fibrosis Association. Since spring 2018, it has been donating 20 Czech crowns for each Air Shield protective neck gaiter with parrot design sold anywhere in the world. This design came from the Respilon competition for children by children, and its author is 14-year-old Carolina. So it's this one. So really they created product more friendly for young CF people. They also, as I told, they also support and cooperate with our Slovak CF Association and also with your Ukrainian association. They sent many their products as a donation when the COVID started for Slovak CF Association, so we distributed it between CF patients. And when we had this online workshop, they also sent to Ukrainian CF Association a big amount of masks which were distributed, and also for this workshop. They also sent air shields, which we decided to donate directly to CF patients here in Ukraine and in Slovakia, not to participants, sorry, but I think that the patients need it more. So I give some of these scarves to representatives of patient organizations, but also to some doctors who from different regions of Ukraine. Some pictures. Here are some. Maybe this video I am not able to run. And We believe in giving back at Respilon, which is our company's social responsibility. We have helped charitable organizations through local and worldwide projects in cooperation with partners from hospitals, charities, and foundations. A net of non-profit organizations, healthcare institutions, and other entities with which Respilon cooperates at the Czechoslovak level is still extending. Before spring 2020, we have organized educational events in favor of these partners, and we like to participate in their events too. So I believe they will attend personally our planned conference next year, because they also attended our Slovak conference where they also donate many masks, but the people can talk with them and make some deals. We provide our products to our partners for an advantageous price or as a gift. We mutually share our experience concerning protection of the most endangered patients and increase awareness of modern nanofiber aids. We are mostly happy when satisfied users of nanofiber products contact us. Now, to thank us, let us know that our face mask, neck gaiters, and window membranes are helping them. Such moments confirm that your everyday work is meaningful and provides us with the energy needed for our future activities and projects. In 2021, it will remain one of our important topics to help those who are disadvantaged. The common denominator of our project will be the health protection, which is why we will include exclusively nanofiber products used for filtration. Thanks to them, we are able to support what our company's motto says, life's worth it. So, thank you for your attention, and use good way the mask.
Thank you very much, Katerina, because our patients really, they received such masks and scarves, and they are very satisfied. And also we have an opportunity right now to see how it works, because all of us had such a gift from you. So this is really convenient, especially when there was such a terrible heat in Kiev and in regions as well. Some of people now are wearing masks, some not, but in our case, it's very strict. And in Kiev, nobody lets you in any shop or in any public bus without a mask. And when you put on this mask, normal, which is really developed for easy breathing and for keeping all harmful particles, this is really great gratitude for that.
Thank you so much, because a lot of participants also got a part of it and got a present, the mask with cuprum and with nanofiber and cuprum, which has bactericide effect. So this is the double protection from different infections. And I'd like to give the floor to Voloshina Larisa, the head of Ukrainian Association of Cystic Fibrosis. And what her speech is the Ukrainian Association of CF Support and Protection of Patients with CF in Ukraine. Mrs. Larisa, the floor is yours. Good afternoon. I've changed the name a little bit, but still it resonates with the CF in Ukraine. The dates today, yesterday, the day before yesterday, this is my daughter who is the motivator for me to fight every day. And now I always keep these slides because I believe that they are really actual, and all patients and doctors have to know about what way the patients get the treatment and where the budget goes and from where we can get and what. So the first thing that we saw is for sure the state program. From this year, it is joined, and it is the provision of the citizens with CF. Starting from this year, the provision will take place with the help of the state company of medical procurement in Ukraine. Currently, there is the tender, and we expect that maybe in November we will get what had to be done at the beginning of this year. And also, we shouldn't forget about the fact that the important part of the provision is on the regional level, because without the support of the regional authorities on the places, I think that no patient would survive in our Ukrainian realities. So I'd like to really thank everyone who deals with getting the right to live for such patients in the region. Of course, I'd like to thank Mrs. Nadia, who is here. She's done hard work, of course, but honestly, without the daily reminder about yourself in the department to the deputies, it's impossible to receive some provision. And also, I hear partly from parents and even from adult patients that some people still don't know about such Order 1303, which speaks about free, non-stop provision with ambulatory medications by location. You have to know it for sure, that everything that the child needs, everything that the adult patient needs, every patient has the right and has to get prescription by his permanent address monthly and get the necessary medications. Of course, there are some complications and difficulties due to the decreased financing because it's not there, but believe me, it's possible if you really want and remind about the fact that you are there. And also, you should not forget about that from some regions I received the letters that some people say that there is no national registry, goodbye. And all of you have to understand that and know that there is the order 1172. I will talk more about it later. It's about the expansion of the action of the national list and the conditions the hospital, doctor, department, under what conditions it's possible to procure the medications which are not in the national list. And then again, we know about the fact that in some regions, on the level of regions, on the level of department, if there is no provision, Department of Health, then there are regions which took the responsibility of the Department of Social Care. So the department which compensates financially, monthly, or once in 6 months or once a year with the transfer to the bank card of the patient, and the patient himself or herself makes the decision about what he or she can buy based on the needs. And finally, why I always show this at the end, the charity fund. Yesterday we spoke about it a little bit, and I do believe that charity funds have to be addressed at the very, very end, because the law is the same for everyone. In every place, in every region, the law, the order, you have to demand on the level of the state, on the regional level, where the patient is and lives. It's really important because, in my opinion, and I always speak about it, maybe parents don't like to hear that, but the state, if it has to do it, it will do it today, tomorrow, after 1 month, and after 1 year. And charity funds, I'm sorry, they have to help in the case when the child, the person, ended up in very difficult conditions and suddenly, then of course charity fund is there to help. Everything else you have to demand from the state, for the state to work on behalf of the patient. I decided to keep this slide from previous conference because it's really indicating in terms of the funding and allocated money and the growth of the budget annually on children and on adults. As I've said, currently, this is the combination of programs, and we will speak about the citizens with the CF. And unfortunately, the Ministry of Health doesn't work the way we want it to work, because this is really sad, but we have to speak about the fact that currently we still have the procurement from 2020, and children and adults will get the medication from the budget of 2020, maybe not earlier than in October. These children will get the medication. So then again, we go back to the regional levels where we have to solve these issues depending on where we live. Here you can see the graph about the fact that every year we try to do the way that the funding could be increased and the budget could be increased, and it's really important, or at least for the budget not to go down. And we stand up for it together with Lyudmila Yosipovna, Gledelova, Natalia Palivna, the speakers we heard yesterday. And this is a really important slide because, yes, we've heard from our European colleagues that in Europe, in developed countries, about the correlation of adults and children is 50-50, or even more than that. 60% is adult population and 40% is pediatric population. Unfortunately, in Ukraine, we have this data, and we will try to do our best so that in 9-10 years, we could get a bit closer to your indicators. And I'd like to stop on the legislation. So now we have to understand that there is the law about decentralization of the authority, where all the money stays on the regional level. Almost all the money stays there. So when you hear there is no money, it's not true, it's lie. There is money, you have to remind, you have to speak about yourself. That's the first point. Then, under what conditions, why it has to be done, why should the funding be found? Because there is the law of Ukraine about orphan patients, Article 53, Part 1, which speaks about the fact that the patients have to be provided with continuous lifelong and for free with medications. And it's important to speak about it every time when the person goes and asks for help and proves to the authorities and officials that the person needs the treatment. It's really important. That's why when we receive the answers, based on the received answers, we can go to the lawyer and we can go to the prosecution and continue and sue the state, saying that the state does not fulfill the responsibilities. I said about it yesterday, and I want to say today that currently in Ukraine we have 2 court cases we won for the patient. When the woman lives in the village and she couldn't receive the most important things, and currently it was approved Bormitop, Colomycin, and Ursafalt and other medications that the child needed. So you shouldn't be afraid. You just have to prove every single time that you have the rights, and you have to know your rights, that we have all the reasons to be provided with the medications, regardless where the person lives. I briefly mentioned about the Order 1172, which speaks about the fact that the medical institutions and the regions can procure out of the national list, and based on this order, there is just one passage which I put into the presentation. It's really big, and if anyone is interested, you can see that if they say that there is no right, it's not true. We have the right to get this or that provision. In terms of the concept we heard yesterday, also I'd like to remind today about this really important document, which was, the discussion took place last year, but about a month ago, it started functioning, about the document about the controlled access. So what does it mean? It's a really important document which will provide us the prospect for the future to invite to cooperation the vertex modulators, because based on the execution of such responsibilities which are in the agreement of controlled access, Ukraine has the chance for 3 months to receive the medication if the state agrees, even without the registration, under the condition of absence of registration in Ukraine. But after, there are some conditions which have to be fulfilled by the company which wants to realize one medication or the other. It's also important to say that starting from the December last year, there was an order approved, 1300, that the medications, why we also fight for Bromitop on the state level, we really want it to be on the state level. The provision of this medication should be received by everyone, on top of that from the central authorities. But there is the order which says that to have the new medication in the nomenclature, it's important to assess medical technologies. Without it, no medication can be realized or procured at the expense of the budget. So that's why we face some difficulties in this regard. Nevertheless, if we speak about the inhalation medication Bromitop, so the regional state administrations have to provide full provision to everyone who needs that. And in my turn, I'd like to ask all the doctors, those who don't do it, please, we still have old versions of the protocols of the 2016, and after page 40, it says that this is the first line, the prescription of topromycin for the patients who in culture have the Pseudomonas aeruginosus chronic form. This is a really important medication which needs to be used, and after the use, we see positive dynamics. In terms of the agreement of controlled access, I won't dwell on it for a long time, but there are important aspects that all the companies for the future have to have the interest to cooperate with Ukraine if we speak about the central level, because the state negotiates directly with the company, and for Ukraine, it is presented like Ukraine gets hidden price. So the price, let's say we will sell one medication or the other, no one will know about it, only the company and the ministry. So this is a really important document, and for the future, I think that we will use it because all of us want to receive modulators. And you know, yesterday, Natalia Palevna remembered a little bit about the concept, a very important document, And we all hope that maybe in September, as it was mentioned before, the Ministry of Health said about it, it will work in the frameworks of this document. There are some particular aspects and things we need to speak about, in my opinion. Right now, the referent expert centers are being defined, and from us, they received a list, a letter. It's really big. I want to say that we submitted the definition and the criteria that show that this institution or other institution can be considered as the center of cystic fibrosis. 4 elements it has in itself. For sure, education of medical workers. We even considered the point to have the opportunity on the state level to exchange experience at the expense of the state, so that the doctor wouldn't need to look for the opportunity where to go and how to get educated, but for the state to write it on the state level that it's important every 4 years to visit European CF center to increase the qualification. It's just a plan, but you know, what will it be like? We really persist on it, and we hope that it'll be put to practice. And one more point, multidisciplinary team we've mentioned, and how important it is to have all the key doctors at the place, ambulatory provision and inpatient requirements, inpatient department requirements to which we have to adhere. And currently, I'd like to say that all of us and a lot of doctors, in particular Lyudmila Yosipovna, Natalia Palivna, Gledielova, Makuch, Lena Vasilyevna, and other specialists, Nadia Mykolaievna, we are the part of the work group which works on the protocol of treatment. According to the State Expert Center of the Ministry of Health, we hope that in December we will have the new version of the treatment protocol. But then again, the ministry says one thing, and then we have absolutely a bit different information and the product at the end. But it's really important to know that we are working on it, and one session has already taken place. It's a short schedule. The second session will take place on the 30th of July, and the 31st of July, the session will be in Zoom because a lot of doctors from different regions will participate. And from the association, we've written the letter so that the mandatory condition could be to include the transplantologists in Ukraine into this session, because there are some aspects which we'll have to implement and adapt to our realities. And I'd like to remember very acute question of modulators, correctors, and so on. And we discussed among patients. All of us understand that this is our future and work which will be done. But to do that, we have to go through a specific way. We've done Zoom meeting, wrote letters.
I received several responses from Vertis company, and I wrote to Sanofi, because in Russia, Sanofi is a representative office that sells modulators, and it was suggested that until the end of this month, they will meet with me. I also asked to conduct a double meeting. So the second meeting would be held in Zoom, and physicians and heads of our local leaders, regional leaders of our association would be involved. Why? Because it's the activity of mothers locally is very important. And then already the information will be spread. But we are moving in this direction, and we need to know that there are certain procedures that we have to undergo, for example, without registration, without evaluation of medical technology, without explanation to any innovations company, and showing what a company will have if it enters Ukraine with this technology. We won't be able to ensure that for all our patients. These are very important points, in my opinion, which are parts of a happy life for our patients. It's adaptivity, positive attitude, and it's very important. These are very important components for every patient. I apologize to physicians, but you can miss several inhalations. But if a child is in love, if she's or her happy, if kids are going to some parties with friends and comes back in good mood, and after that a child does inhalation, maybe just one inhalation instead of two, but that's already very important when the emotional component is elevated. Physical load is what we discussed many times these years, that there should be balanced nutrition and physical exercises and 100% provision of medications. Of course, for example, patients think that if they get modulators, everything will be wonderful with them and they will have a pretty beautiful life. But we heard many times from our European colleagues that positive dynamics will only be in case there is in case that everything that is mentioned in Ludmila's report yesterday, when all recommendations will be complied with, when there will be 100% compliance, when a person will undergo intravenous therapy in time, of course, in that case, modulators will be effective. And, you know, from time to time in some regions, we still observe differences and discrepancies between government officials, physicians and patients. But even when I recall, you know, the very first session, I would like to say that it is very important. Maybe it's only my opinion as of a mother of such a child, but a patient has to be in the center. Everything we do for the sake of a patient, our meetings, our trainings, and patients should have, let's say, as much positivity in life as possible. I would like to remark a little bit. We have an adult physician. She went to Italy for 2 weeks to see how CF center in Naples is working. But when she came back, adult patients said, I asked them, has anything changed? They said, she became so pleasant. She's always smiling. She's coming in an elevated mood. She doesn't give observations like you're sitting in her own way, you're doing something in her own way, but she just sits down and asks, how are you? What you doing? What is your interest? So it's such an impression that a person came who actually, it's that she's not physician, but she's a person who just comes to communicate with you and feel empathy to you. And then step by step, she comes to the point that she, as a physician, is supposed to evaluate my condition. So it's not done right away. And this is very important. Also, we would really like to have such an approach among physicians when all of us, when we have the same goal and when we are all moving in the same direction. And here I would like to say, would like to show a little video with our CF patients, mostly adult patients from all over Ukraine. They agreed to be on this video, but since I have problems with sound here, we'll try to launch it. Is it possible to launch the video? very grateful, and I have the final expression. Don't have to launch it, but I would like to just name it. Not always an action can lead you to happiness, but even only action can lead you to happiness. We can say it about health and about relationships between ourselves, between a patient and a physician, between a patient and in our society on the whole. So I would like to thank each of you indeed, because every one of you is an individuality who deserve attention and respect, to be heard and to be learned from. So thank you very much, and thank you very much for your attention. Let me sincerely thank Mrs. Larissa for her courage as a parent, as a mother, for her enthusiasm, for her energy, titanic work which she is demonstrating, and hope for the better, for changes in our society for the better, regarding orphan patients and regarding CF patients in particular. We sincerely thank her for her everyday hard work, for her energy and hope. Thank you very much. We wish you health, inspiration, and we wish you indeed to continue achieving what you're achieving, because you're achieving a lot actually. Now the time is running out, and now we're actually approaching the end, the completion of our workshop and our communication at this forum. And with great pleasure, I give the word to Katerina Stepankova, who is the chief of the CF Association in Slovakia for over 20 years. I'll repeat once again, she's the initiator of the project that is implemented in our country, in our Frankivsk, the CF Center and the nanotechnology transfer for patients with CF. We thank her a lot, and I give the floor to her now. Thank you.
Good afternoon. I am back again. Thank you, Larissa, for this amazing closing presentation with very beautiful pictures of many beautiful CF children, adults, their parents, and all CF community. I also want to say thank you. You are here until the end. And I have only very short presentation about the future, about our next plans. We were successful with another project from program of cross-border cooperation with Ukraine. So we will continue our activities here in Ivano-Frankivsk region, but I suppose it's open for people from all regions of Ukraine next 2 years. So I believe this is not last time we are here, and I believe we will meet much more times. So our new project is, his title is Modernization of Cystic Fibrosis Centers in Košice and in Ivano-Frankivsk. It means that we will improve especially the equipment in centers in Košice, for Eastern Slovakia, and also for Ivano-Frankivsk region, for children, but also for adults. Today, I first time met Dr. Filipova from Adult CF Center in Ivano-Frankivsk. So I also wish to meet you again, visit also center or place or ambulance where adult CF patients are treated here in Ivano-Frankivsk region. And I believe we will find some possibilities of support also this place. Čo? Aj, čo mám? Dobre. So we want through this project improve the quality of care and quality of therapy and diagnosis of this rare disease, especially through purchasing of new and necessary equipment for CF centers. So duration of this project is since 1st June, so we just started, and tomorrow we have first meeting of our teams here in the hospital, and it will be two years project with this budget. Okay. I feel tired. So in this project we are only two partners, Slovak CF Association and Ivano-Frankivsk Hospital, with the same teams as in this project. But as I told 2 days ago, it's much more wider team because we have more people involved in activities of this project. Here we are. These are objectives of the project. And here are main activities we plan in this project. So modernization of equipment in centers. So first we really want to buy for Košice the Makrodukt, the modern sweat machine. For Ivano-Frankivsk Hospital we buy from this first project. Then I think important is to purchasing the Simeox for Košice and also for Ivano-Frankivsk. So we bought one for adult center in Košice, and really the physiotherapists and also CF patient like this machine. And so we plan to buy this machine very soon for Ivano-Frankivsk. So I believe we will be able, together with Igoshe, to organize training. So when we buy it, we would like to organize 1 or 2 days training with support of physio assist company here in Ivano-Frankivsk. It will be for physiotherapists, so all physiotherapists will be invited for this training. And we will need also, of course, some patients who cooperate and will do models for this training. And then there are many other important machines. And we also plan to buy more nebulizers and flutters because it's never enough. And we again try to bring some more physio tools and equipment for CF patient. Like during this course, every patient who was here received Respimer and know how to use it for nose hygiene. So in education activities, there are not many activities. So we plan Slovak CF conference in 2022 in autumn. But from the first project, we plan Ukrainian CF conference. I believe it will be possible in April or May next year, again with cooperation with Ivano-Frankivsk Hospital and Rimon. We've done excellent work for all these events. And then we plan multidisciplinary team training for teams, so we will see how we manage it. We find some maybe French team or Swedish or Czech, or we will see. And then the third activity is we just want to continue with registry activities in Ivano-Frankivsk, but I always feel how important is the registry for whole Ukraine. So we had a very nice meeting yesterday about this issue, so we can continue. And Olga Fedinska, who do this activity, I think she's ready to help also to people from other regions of Ukraine. And very important activity is the application CF Hero. We had here also three meetings around this. And we have good plan. We have responsible person from Ukraine and from our team. So I hope that maybe next year the application will be ready for in Ukrainian language and will be ready for your patients. And I am sure it will be very helpful for motivating the patients who like this way of motivation. And I am thank you that Jakub arrived, because it not many, the people still fear to travel to other countries, and Ukraine is the country which the people are somehow afraid. Then we do the book of presentations from Slovak CF conference. We have from previous one, you can take how many you like to have for you or for your colleagues. There are always many interesting informations, especially in this one there are more presentations about CIMAOC, so you can read more about this equipment. And the lobby, of course, it's always important activity, never-ending story, and we win our fight for Kalideko, Orkambi, and Kaftrio in Slovakia. And I believe you win it too, and your patient will have these drugs too. And this is, I like this picture because this Ivano-Frankivsk sign is not there now. There is some new one, but I like this old one. And this is the end. So.
Thank you so much. Thank you so much, dear Katarina. Thank you. I'd like all of us to applaud very actively to this woman. She's done a lot, and she really is doing a lot. You all have seen that. She's great enthusiast, very active, both for Slovakia and for Ukraine, Ivano-Frankivsk, for the whole Europe, because we've had many conferences, workshops, seminars, and she's always touched by the problems, by all problems which every region unfortunately has. So we sincerely thank you. And the next speaker I want to invite is the project manager from the hospital. This is one of the participants of this project, the deputy head of the pulmonology department of regional child hospital, Makyan Monika Valerievna. We've spoken so much over these 3 days. І давайте запросимо ще пані Наталію, це основна людина цього воркшопу. We've discussed a lot over these 3 days, and I think that over all this time, I don't know about you, but about me, I didn't even need to drink coffee because I was so energetic, and I wanted to be here and there, and I didn't manage to see kinesiotherapy fully, and we wanted to listen to lectures in this conference hall. The one thing is clear: when you have the aim, you don't have anything that's impossible. And since we share the same aim, patients, doctors, parents, I think that the success is guaranteed by 100%. I really wanted to thank Hugo Gosche for his experience, knowledge, and powerful, positive energy, the message that helps motivate and inspire children. We welcome you to come here with Matilda again. Thanks, Patty, who is also very positive towards our children, and she always managed to say something. I don't see her here, so anyway, I want to thank Katarina, without whom it would be impossible. Really, this is the person who is so touched and feels all the problems. Probably with daily work, you've achieved the success at your place and you want to help everyone else. I want to thank Tanya and Renata who are always here and their work is always done, and it's maybe not noticed, but I'd like to emphasize them because they are always in the shade. I'd like to thank Natalia, who wonderfully, as always, organized this event, and everyone is really pleased with everything. And thank you to all the participants of the parent committee, to parents who are really active, with whom you can move forward and not be scared of any challenges. And I think when we unite, there is nothing scary, neither the funding that we cannot receive fully. And I think that we will succeed and our children will live as long as all the other people. Thank you. From my side, I'd like to thank everyone, all our guests, participants, organizers, co-organizers, for the hard work and time which you put into this event. And I'd like to join to the words of Mrs. Larissa Voloshina about the fact that we should act. Only action can lead to the result. That's why I propagate such lifestyle, that action is the first, goes first. And I also want all of you to also act, have the aim and move forward. And please don't forget, and I think all of you remember, that all of this is done for the patient. Thanks to everyone, and I hope that all of you will have very nice evenings. And also I'd like to invite everyone for the farewelling, but we don't say goodbye, we say see you soon. So for the farewelling for Shay, and I think that we will have the opportunity to communicate informally. And those who stay even in Ivano-Frankivsk, I wish all of you to enjoy your time in Ivano-Frankivsk and to have very nice continuation of the day. And one more time, I'd like to say that I'm very happy that we've managed to do it in this live communication format, in the format of face-to-face communication, that we've looked into each other's eyes. And I hope that our future meetings will also be in the same face-to-face offline format. Thanks to everyone again. I'm sorry, I forgot and I understood. I'm so sorry. I'm standing and thinking that I've forgotten to thank very important people. I've forgotten to thank our colleagues from Lviv. And all this time I looked at them and I remembered, you know why? Because you are our people and the person who is always near us. We value such person the least, but the contribution of such person is unbelievably huge and long-term. And given how long you've worked and over these 3 days, how much you've told us and helped us, you understand that the more you understand, you understand nothing. So you always have something to learn. Thank you, Lyudmila Yosipivna, Halina Vasilyevna, thank you. And we hope that we will continue our tight cooperation. Thank you. And a short remark. I really wanted to remind you, you remembered about it, but since I introduced our National Medical University, I have the task to say from the board of the university, from the pro-rector of our university on treatment work, from Kodlevita Strazinovich, the greeting to our forum at the final stage. And he couldn't greet us with the beginning, but I have this message which I have to say. The university always supports, and basically I'm the worker of the university, but all these aspects have joined so much of science and practice in terms of cystic fibrosis that we don't even divide into the team of hospital and team of university. All of us work together. We have the same task and the same success. So I want to sincerely thank everyone. And you want to say a few words, so please, Lyudmila Yosipivna. She's the head of the CF Center of the Western region for many years. And we really value her as a consultant, as very devoted and experienced person who deals with patients day and night. I'd like to thank everyone who is a part of this project. Katarina, Natalia, our colleagues, Monica, Nadia Mykolaievna, and without them, our colleagues from France, because all of us were educated, you saw your children, you can see something that we can correct, and you will help us with this. So to be in such international multidisciplinary team is high honor for me. So I'd like to thank for that. I'm convinced that this is the project so humane, which doesn't work only in Ivano-Frankivsk. It's all Ukraine project, because the dissemination of the information will take place for sure, and it'll be fast. And also, I am very happy for you that this project found its continuation, and you will continue working for 2 years with this support. So you will learn the steps from our colleagues, Katarina in Slovakia, which is very close to our country, neighbor, and mentally close neighbor. This is probably the God blessing. So we can take advantages of all the possible opportunities. You are lucky to be the border region, and we are not lucky, because we planned to have the cooperation with the Lviv region, but it turned out to be with Ivano-Frankivsk. So we are so happy for you. And if you need some support or help, or from me or Halina Vasilievna or Svetlana Mykolaievna, please ask, and we are always ready to help. We believe, we see, and we are sure that you are also lucky. So all of us are lucky, because we will continue working for the whole Ukraine. And I'd like to thank all of you here for being here, because if we didn't have such interested community and audience, we wouldn't have anyone to share the experience with. And the final remark, together with Lyudmila Yosipivna, we are going to consult the child with CF in the hospital. So our work is not over, we continue working. So thank you so much for agreeing.
I have here many friends. All of you are my friends, and I really love to travel to Ukraine, not do online things. So have a nice trip home, and see you soon again.